I am ready. Can you hear me? Can you hear me
We can.
properly?
Perfectly.
Excellent. Well, good morning, everyone. It's a pleasure being here today. Thank you, Jeff, for inviting me. As presented, my name is Nadav Shefi. I'm an attending anesthesiologist. I'm also a critical care physician. I work at Rabin Medical Center, which is a large trauma center, a referral center in the center of Israel, very close to Tel Aviv, which is the city most people know of Israel. I'm also the head of the Israeli Association for Trauma and Neurosurgical Anesthesia. Now, to be honest, I'm not a huge fan of obstetric anesthesia. I guess most of us aren't. But the reason I asked Jeff to talk about trauma during pregnancy today, and I will explain about it a little bit in a second, is that we see a lot of pregnant trauma patients in Israel. I will explain why. I will jump to the end of my discussion already, and I will let you in on a secret, which you probably already know, which is we know how to treat, we know how to anesthetize trauma patients. We also know how to anesthetize obstetric patients, and combining these two isn't that difficult. I will start by saying that I have, unfortunately, no one is paying me, so I have no relevant disclosure. Now, why did I say that as an Israeli, I'm let's say, allowed to talk about trauma anesthesia or pregnant anesthesia? This is just, I want to show you some data from Israel. Now, Israel is a religious country. Now, we are considered Western world, but this is debatable. And if we look at this graph, which is the fertility rates from 1970 to 2020, we can see that while the United States and the European Union are here, it's about 171, 1.5 for the European Union. In Israel, it's almost double that, it's 3. Now, fertility rate is defined as the number of children that would be born to each woman if she were to live to the end of her childbearing year. So 3 is not that little, this is only the average. Now, this is a graphic representation of Israel. It's the map of Israel. This inset here is the center of Israel. Now, this is Hebrew, I'm sorry, but I will let you, this is Tel Aviv, okay? And the purple circles are fertility rates. The darker the circle, the higher the fertility rate. Those very, very deep purple are fertility rate of over 4, which is a lot. This is Tel Aviv. This is where I work. And this right in the middle, we have this big dark purple circle, which is the city of Bnei Brak. This is the largest ultra-Orthodox city in the center of Israel. And the fertility rate there is extremely high. I mean, it's over 4, but it's probably more like 8 or 9. So we're talking about a lot of women who are pregnant at any given time. And if you combine that with the notoriously bad traffic and horrible road culture we have in Israel, we get a lot of pregnant trauma. Now, most trauma is really, most trauma for pregnant patients is motor vehicle collision trauma. And falls, assault, gunshot wound, and everything else is a far away second, third, and fourth. Now, this is not a new data, right? It's 2008. This is from the ATLS, but really the epidemiology of pregnant trauma doesn't really change. And obviously, most of the injuries are blunt injury from motor vehicle crash and other mechanisms, and very few are penetrating injury. About 6, so the number people like to say is that about 6 to 10% of pregnant women will experience trauma during their pregnancy. The majority of cases are really minor one without any consequences. But if we look at this table, so that's it's data from a systemic review which was done in 2013, we can actually see that the number of domestic violence is the highest. But domestic violence is really usually minor injury, and most of the serious injury comes from motor vehicle crashes, which is here is the prevalence in pregnancy is 207 for every 100,000 live births. So that's kind of the epidemiology of that. This is a study that was done at a level 1 trauma center in Los Angeles between 2009 and 2019, and it looked at pregnant trauma victims, and the results were quite interesting. So they had 145 cases of trauma patient versus almost 7,000 non-pregnant women who had trauma, which is about 2% of the cases were trauma cases. So they, what they did was they matched pregnant patient for age, seatbelt use, and airbag deployment with a non-pregnant patient at a ratio of 1:3, and they got 145 pregnant patient, trauma patient versus 387 non-pregnant trauma patient. And really most injuries for pregnant patients were minor injury. And you can see here that only seven patients, which is 5%, had an ISS over 15 versus 34 patient, which is 9% of the non-pregnant patient, which is still not a lot. And most injuries really were minor injury. Now, at the time frame that they checked, and this is not shown in these tables here, there were only 5 cases of in-hospital deliveries following those traumas, which is only 3% of the cases. And 3 of them were induced because of what we call non-reassuring fetal heart rate. One of them was a preterm labor, and one of them was what we call perimortem or post-mortem C-section, when the mother dies and you try to salvage the baby, and unfortunately the baby did not survive in that case. But this is not, the numbers are not very high for major trauma patients. Now, just to get into the kind of spirit of things, let's imagine this, and we'll see a short video here. This is a trauma patient we need to take care of. Look at this car. This is a bit graphic, I'm sorry in advance. So we have a head-on collision, moderate to high-speed head-on collision with a lamp post. And we are called to the ED as part of the trauma team to take care of this woman involved in the crash. Now, what we get is really a 27-year-old female who's 28 weeks pregnant. She has no prior medical history that we know of. As we could have seen, she was involved in a motor vehicle collision, high speed with a lamppost. She was the driver. There were 2 other occupants of the vehicle. One died on the scene and the other was also severely injured. The airbag did deploy during the collision, and there was a prolonged extraction from the car by firefighters. Now, while we ponder about what we want to do with this patient, let's talk a little bit about physiological changes during pregnancy, which are relevant to treating trauma. There are a lot of changes, and I'm not going to talk about all of them, but let's see what is relevant to us as trauma physician. Now, remember that throughout pregnancy, total body water increases, and it reaches about a 50% increase, which can translate to 6.5 to 8 liters by the end of pregnancy. Now, it's true that red blood cell also increase, but this only increased 20 to 30%. So proportionally, it's lower to the increase in total body water, and we get what we know as anemia of pregnancy. Now, if we look at the graphs here, which show us hemodynamic parameter throughout the gestation, and let's, for the moment, just look at the orange one, then we can see that both stroke volume and cardiac output increase quite dramatically throughout pregnancy. And really, cardiac output rises almost 30 to 50% above normal by the end of pregnancy. Heart rate increases. On the other hand, the systemic vascular resistance decreases, and blood pressure is usually 10 to 20% lower than the non-pregnant patients. And we'll talk about what happens when our patients are supine in a second. Now, towards the end of pregnancy, the placental blood flow takes almost 25%, so that's a quarter of cardiac output. Now, during severe injury and hemorrhage of the mother, there is what we call autotransfusion of blood from the placenta back to the maternal circulation, which can really mask a large amount of bleeding. So our patient can appear to be hemodynamically stable, but really have bled a lot, and she might not be as stable as we think. Now, we all know that, but remember that during the later stages of pregnancy, the gravid uterus compresses the aorta and the inferior vena cava, and so reducing preload, increasing afterload, and really this might cause a severe decrease in cardiac output when the patient is supine. So we all know that when we are treating a second trimester, third trimester patient, we need to tilt her on her side at least 30 degrees. Now let's let's go back to our patient. But first of all, and this is something that I would be happy if you remember by the end of this talk, when we are treating a pregnant trauma patient, we are only treating a pregnant trauma patient. I really don't like, I know that some people say, oh, we are treating 2 patients because there's the mother and the fetus. No, We are only treating the mother, and if we treat the mother properly, then the fetus well-being will also be better. This is very important to remember. So we're doing the IBC on this lady, and she has remember, we just got her from the accident she was in. She has a clammy cold skin. Her blood pressure is 100/60. She has a pulse rate of 120, sets of 95%. She's Glasgow of 10. There's a seatbelt sign across her abdomen. There's laceration on her head, an open fracture of the right femur, and her focused abdominal sonography for trauma is positive for fluid. Now, if we sum it up, she's semi-conscious. We are suspecting a head injury, maybe a chest injury. She's not so hemodynamically stable, or is she? We're not sure. And multiple injury and positive FAST. Let's talk about FAST for a second. Focused abdominal sonography in trauma, extremely useful, even twice so in pregnancy, because we can get all kinds of pregnancy-related data. So this is a very short video of focused abdominal sonography in trauma. Shows us also what we can learn about the status of the fetus. You can see the baby. Okay, so in our case, our lady, the hypothetical patients we have, the FAST showed us that we have some fluid in the abdomen. Now, the question is, and if we would have been in, not in a virtual meeting, I would actually ask you what you think, but we are in a virtual meeting, so I've decided to not do that. I will just ask and answer myself. So what can we do for this lady? We can either transfer her directly to the OR for explorative laparotomy, or maybe she needs a total body CT. Do you want to transfer her to the ICU for observation and treatment because she is semi-stable? Or do you want to check what's going on with the baby and do an urgent tachometry, which is the fetal heart rate monitor? Now, as in real life, there is no correct answer, and I'm not sure what it is. And we could probably have had a nice debate about it, so I believe this patient that we are describing here is marginally stable because he has a blood pressure of 160 with a pulse pressure of 120. We didn't give her blood yet, so we don't know if she's how she's going to react to that. And she had a positive FAST exam, so probably I would take her to the OR. But if you're working somewhere where there's a CT inside your ED, your emergency department, and it's very fast to do, you can argue for taking her to the CT primary. But what I really want to talk about here is about the radiation of pregnancy. So again, I will start with the bottom line. When we need to do imaging in a pregnant trauma patient, we do whatever it is we need to do, regardless of the fetus and regardless of the stage of the pregnancy. Nothing we can do will harm the fetus more than not doing the correct exams and missing a diagnosis. Now let's talk a little bit about numbers. According to the American College of Radiology and other relevant societies guidelines, fetal radiation doses less than 50 milligrays are not harmful to the fetus, regardless of the stage of pregnancy. Now, abdominal CT, which is abdominal CT or angiography CT, which is the highest, the worst one, is only 25 to 35 milligray. So we can actually do whatever exam we want if we need to. Of course, I'm not encouraging anyone to freely radiate the patient, any patient, not just pregnant patient, but definitely a pregnant patient is not a problem when thinking about what imaging we need to do. Now, unfortunately, FAST or focused abdominal sonography in trauma is not sensitive enough because the sensitivity for detecting intra-abdominal injuries of FAST is only 61 to 83%. So it's not enough for normal trauma patients or non-pregnant trauma patients. It's not enough for trauma patient with a high suspicion of intra-abdominal injury. We want to know what's happening there. So what happens? Let's talk a little bit about what unique injuries of pregnancy can happen. So really, what we need to remember is that until approximately the 20 weeks of gestation, the uterus is an intrapelvic organ. So it's protected by the pelvic bones and less susceptible to damage. What happens is that about after 20 weeks, the uterus, it grows and comes out of the pelvis and become an abdominal organ, and it might sustain, or there's a higher percentage of damage that can be sustained by the gravid uterus. Now, so we're talking about trauma-related or pregnancy-related trauma injury. What is the most common pregnancy-related injury? So, is it rupture of membrane? Is it uterine rupture? Is it preterm labor, or is it placental abruption? So I will give you 2 seconds to think about it, and then I will answer. The most common injury is placental abruption. It is definitely the most common complication in traumatic pregnancy injury. It occurs according to literature, in about 5% of injuries, but really the truth is that it's probably much higher. What happens is that in blunt trauma, energy that is absorbed by the muscular and the elastic uterus is transmitted to the more rigid placenta. The shearing forces that are created at the interface usually are able to cause disruption in the attachment and placental abruption. So we have a picture here, and this is how it looks like on CT. Now, placental abruption can have all kinds of unwanted repercussions. So starting from premature rupture of membranes, premature birth, maternal DIC, fetal hypoxemia, and unfortunately also fetal death if untreated, but even though there's not a lot of treatment once an abruption has occurred. Now, a much more severe complication, but fortunately quite rare, is uterine rupture. This happens in less than 1% of major trauma pregnancy or injuries in trauma pregnancy. And the most significant risk factor is patients with previous cesarean section. Unfortunately, when uterine rupture does occur, there is up to 10% maternal mortality, and fetal mortality is almost universal when this happens. Additional complications that can occur during pregnancy is rupture of membranes. There's a risk ratio of almost 2 for preterm labor for trauma patients compared to non-trauma patients. And also quite serious, but fortunately very rare complication is amniotic fluid emboli. What about outcomes of trauma in pregnancy? What happens to these babies and mothers? So this is a retrospective cohort study looking at all deliveries between the years of 2007 and 2011 in the state of California. And the truth is, and this is a little bit surprising, out of 2 million, almost 2.5 million pregnancies, there were only 1,200 cases of trauma registered, which is almost 0.05%, which is very low compared to the 6% we talked about at the beginning of the lecture. But this is the data. And if we look at this data, then what they looked at composite perinatal outcomes, which is fetal and neonatal death, seizures of the newborn, asphyxia, hypoxic ischemic encephalopathy, and intraventricular hemorrhage. And really, the rate is obviously much higher for patients involved in trauma compared to patients not involved in trauma. It's 3.1% compared to 0.9%. Again, if we look at fetal demise, also 1.9% in trauma versus 0.53% for non-traumatic deliveries. And this, both of them are only, when you look at term and non-term babies, there are only statistically difference for non-term babies. So when looking at term-only babies, there was really no statistical difference. When we looked at what they called severe maternal morbidity, which is ISS injury severity score over 9, if I remember correctly, then obviously the numbers are much higher. There's 6.8% of composite perinatal outcomes for trauma patients versus 2.5% for this is severe versus non-severe. So severe patient has 6.8% versus 2.5% for non-severe patients. What are the risk factors for fetal loss in trauma? This is data that I've taken from the ATLS. Again, it's not very new, but when we see a patient coming to our ED, when can we think about fetal loss, or what are the risk factors for fetal loss? This would be a maternal heart rate of 100 or over 110, ISS over 9, obviously evidence of placental abruption, high or low fetal heart rate, and the mechanism of the injury, which is either ejection during a motor vehicle crash or being involved as a motorcycle rider or pedestrian collision. I'm thinking about it now. It's like, why would a pregnant lady ride a motorcycle? But why would anyone ride a motorcycle? I'm not sure, but there you have it. Now, this is another study it's a newer study looking at 241 pregnant trauma patients admitted to a Turkish level 1 trauma center between January 2017 and January 2020. So they had, again, 231 pregnant patients. And if we look at table 3, when doing multivariate logistic regression, they found only 3 predictors that were statistically significant for complications. And that was maternal age over 35, 3rd trimester trauma, and not written here is abnormalities on ultrasound that was performed in the ED. And if we look at table 2, we'll see that really all in all, the complication rate wasn't very high. The most, the fetal death were only 2 cases out of 245 patients, which was 5%. The most common complication was emergency cesarean section, which happened in 10 patients out of 245. So this is about complications. Now, so what do we do with this patient? So this patient is in our ED. We need to treat her trauma. We need to treat her pregnancy. How do we do it? This is a very elegant algorithm that was published in 2009. And basically it says, okay, so if the fetus is not still viable, it's below 20 weeks, just do whatever it is you need to do. And once you're done with it, you can call obstetric consultation. When we have a viable fetus that we might save if there's a complication, then we need to put it in the algorithm. But first of all, we will always, if the patient is stable, then we can at some point do like a continuous fetal heart rate monitoring. We can call obstetrical ultrasonography and so on. However, if the patient is unstable, we definitely need to start with our primary survey, our secondary survey. If we have time, we can consider doing continuous fetal heart rate monitoring and tachometry during our secondary survey. But if our patient is not stable, we will just do whatever it is we need to do. Take her to the OR, take her to the angiography suite, or whatever it is we need to do. Once she's stable, we can again do a CT if we need to, an obstetric ultrasound, give a ROGAM if the RH is negative, and then continue a fetal heart rate monitor. And eventually, before discharging such a patient home, we probably need to do some sort of fetal evaluation or obstetric consult. Now, this really depends on where you work. So I work in a tertiary referral hospital. So there's always obstetrician about, and there's always someone to help you with that. If you work in a community hospital, it might be harder, and you need to think about transferring this patient even earlier. Now, these are the most recent guidelines I could find, which is 2015 of a how to manage a pregnant trauma patient. This is the Canadian Society of Gynecologists, of Obstetric and Gynecology, and it's a very long guideline. We will just go over the important things which are relevant for us. So first of all, from a technical point of view, if you need to put a chest tube, put it higher, because obviously the gravid uterus will push everything a little bit higher. So this is the first thing. Now, after mid-pregnancy, tilt the patient on her side. We know that already. Again, O negative blood, probably preferable if we have it. And this is really for pre-hospital consideration. If it's a major injury, you need to transport the patient probably to a trauma unit. which can take care of it. But this is whether it's, this works for trauma for pregnant and non-pregnant patients as well. Now, really what they say here is that treat the mother. Okay, you need to assess, you need to stabilize, you need to take care of the mother before you do that for the fetus. And if the fetus is viable, then you can consider doing fetal heart rate auscultation and monitoring later on once the mother is stable. When radiographic studies are indicated, whether it's an X-ray or CT or whatnot, they should not be deferred for concerns of fetal exposure to radiation. And then again, all pregnant trauma patients, once we're done with our primary and secondary survey, we should do fetal monitoring for at least 4 hours, because the truth is that the sensitivity and specificity, even for ultrasound, is not 100%, and it might miss an injury. So we need fetal heart rate monitoring for at least 4 hours. And the last recommendation, which is also the most kind of dramatic one, is that if we have a perimortem cesarean section, if we have a dead mother and a viable pregnancy, we need to do the C-section no later than 4 minutes following maternal cardiac arrest. So first of all, this is not very, very doable in a lot of cases. And I think it's more like doing an ED thoracotomy. It's very dramatic. We do it. The rates of success are extremely low. There are successes, so you should do it if you can. But again, we shouldn't have very, very high hopes. And usually the babies or the fetus will die in such cases as well. So to sum it up, and I see I was quite fast, basically, this is what I would be happy if you take, like a take-home message to begin this day of trauma talks. A pregnant trauma patient is a trauma patient, and we treat her like any other trauma patient. There is almost always only one patient, the mother. And again, I personally, I accept if someone else thinks differently, but I personally really hate the saying that, oh, you have to treat 2 patients. No, I'm treating the mother, just 1 patient. The fetal well-being monitoring is important. We do need to do it, but it is secondary to the mother's well-being. And finally, perimortem C-section exists, but luckily for us, are very rare and seldom successful. And this is it with my talk. Thank you very much.
Nadav, thank you very much. If I could ask you to stop sharing your screen and obviously hang around for the Q&A session later on this morning. So I'm delighted to introduce our next speaker, and that's retired Colonel Lee Cancio, who's a director at the U.S. Army Burn Center in Fort Sam Houston in San Antonio. He's also a professor of surgery at the University of Texas Health Science Center. So Lee, if you would like to share your screen with us, the floor is yours, sir.
Right. How's that look?
That's perfect.
All right. So I'm grateful for the opportunity to present at this meeting. I am a surgeon at the U.S. Army Burn Center and also the director. And today I'll be talking about the challenges associated with fluid management of critically ill burn patients with the. Now, for purposes of this particular conference, I think it's important to understand that these patients may indeed need operative care during the first 48 hours. That is somewhat unusual, not something that we ordinarily plan for, but certainly it does occur. And then, of course, the other scenario would be the patient in the intensive care unit. When we speak about resuscitation of patients with burn shock, we are generally referring to patients with burn size in excess of 20% of the total body surface area. Although certainly patients with smaller burns, say in the 10 to 20% TBSA range, may also develop burn shock and require what we would call formal burn shock resuscitation. based primarily on intravenous fluids. I have one disclosure to make, and that is that I have an invention that I will discuss in this presentation called Burn Navigator, and I have assigned my rights to that invention to the U.S. Army. My objectives today are to discuss the processes involved in burn shock pathophysiology, to understand the causes and consequences of error in resuscitation, and to discuss strategies to optimize fluid requirements during burn shock resuscitation. Now, Scylla and Charybdis, I'm not sure who came up with this title. Maybe it was me, but I do think it's apt for this particular issue. And as you may recall, when Odysseus was coming home from Troy to Ithaca, Greece, he passed through an area where on one side there was a monster with 6 heads, and on the other side there was a whirlpool, and he had to decide which risk to take. And he decided to take the risk of steering near the monster, because that way he would only lose a few sailors, whereas if he went into the whirlpool, he would lose all the sailors and the boat. Now, I'm not sure which scenario best matches errors in burn shock resuscitation, but I will agree that burn shock resuscitation is indeed one of the most perilous phases in the care of a burn patient. And if we make big mistakes during burn shock resuscitation, a lot of problems may follow down the road and may contribute to or cause ultimate mortality. So let's talk about burn shock resuscitation and under resuscitation. That is, what happens if we don't resuscitate with enough fluid. So burn shock occupies the first 48 hours post-burn in patients with burns in excess of 10 to 20% of the total body surface area. The physiology of burn shock changes dramatically throughout this period, and we must adjust therapy in response and basically be attuned for those changes in physiology. Early and within minutes of thermal, there is greatly increased microvascular permeability, which results in early rapid loss of fluid similar to plasma into the interstitium. Thus, burn shock is first and foremost hypovolemic shock. Meanwhile, there's massive catecholamine release, and this causes intense peripheral vasoconstriction. There's also a variable degree of myocardial dysfunction, which may or may not be evident in a full organism. There is a variable degree of myocardial dysfunction, and that you may not detect, but may be in the background. And all of these issues together combine to decrease cardiac output and end organ perfusion. Now, meanwhile, we need to respond, and rapid attempts to restore intravascular volume, say with fluid boluses or attempts, are usually doomed to failure and to causing over-resuscitation and edema complications without permanently restoring intravascular volume. And you could call that errors of yin-yang or yo-yo therapy. Yin-yang is not a good term. We'll call it yo-yo therapy. And this needs to be avoided. Resuscitation in these patients is usually a gradual process. And furthermore, implies accepting what I would call a degree of permissive hypovolemia, as you can see in these graphs from Dr. Pruitt's 1971 article on hemodynamic changes in the early post-burn period. It is okay to have a degree of hypovolemia, provided we maintain adequate end organ perfusion. What are the end organs that are at greatest risk, and what are the implications of those problems? Studies in dogs have demonstrated that end organ perfusion will decrease within moments of injury. And as you can see here, there is a rapid decrease in cardiac output, as well as decrease in perfusion of certain organs, of which the kidney, the liver, the small intestine, and the skeletal muscle or carcass are key elements. Notice also that if you give resuscitation according to the standard formulas, in this case, modified Brooke formula, you get restoration of blood flow to some organs, but not to others. For example, there was restoration of hepatic artery blood flow to the liver, but not so to the small intestine, kidney, or the kidney. So in particular, notice that blood flow to the small intestine is rapidly sacrificed and is most severely sacrificed. We did some studies of another way of measuring end organ perfusion. We did intestinal and gastric tonometry during experimental burn shock in pigs. And in this particular study, we used a large full thickness burn, 70% of the total body surface area. And then we resuscitated in delayed fashion, namely at the 6th hour, and we did so very rapidly. With that, we noticed more or less simultaneous decreases in urine output, as well as in the regional PrCO2 in the ileum. So we corroborated the notion that the ileum is particular, or the small intestine is particularly sensitive to the effects of burn shock. So can we rely on the urine output as we say we should, as a of sort of vital organ perfusion during resuscitation? And in general, I believe that this remains the case with a few caveats. If you look at abdominal complications after severe burns, we could categorize these into two groups. One would be abdominal compartment syndrome, or ACS, and you can see the Venn diagram on the left. And the other would be mesenteric ischemia and infarction on the right. These conditions may overlap. That is to say, abdominal compartment syndrome, by decreasing perfusion to the gut, can cause ischemic bowel and infarction. By the same token, ischemic bowel can be caused by burn shock alone. So really, this Venn diagram sort of recapitulates the whole idea of trying to avoid extremes of over resuscitation on the left, that is to say, abdominal compartment syndrome, or under resuscitation on the right, manifested by ischemic bowel and infarction. What happens if we delay resuscitation? So delayed resuscitation is an independent predictor of increased mortality. And this was documented by Wolf and Herndon down at the Shriners Burn Institute in Galveston, Texas. In this study, what we saw was that delayed intravenous access was an independent predictor of increased mortality, along with some of the other things such as age in children, lower age in children, larger burn size, and inhalation injury, those being, if you will, injury-associated factors, and then as well as factors that occur during the hospital stay, such as the development of infections or ventilator dependency. So really, the rapid institution of appropriate fluid resuscitation is important for survival. So what is the goal of resuscitation? According to Dr. Pruitt, who was the commander and director of our burn center for a period of 27 years, said that burn shock resuscitation aims to maintain vital organ function at the lowest immediate or delayed physiologic costs. So there's a recognition there that resuscitation does come with a certain cost. So how can we achieve these goals? Well, if we look at the last, say, 75 experience in the resuscitation of burn centers, of burn patients, we see some common themes. We see that burn shock resuscitation formulas include consideration of the burn size, or TBSA, that they then went on, beginning with the Evans formula, to take into account the patient's weight. And also that there's a range in the amount of fluid predicted that's actually pretty wide, between 2 mLs per kilogram per percent burn in the Evans-Brook and modified Brook formulas, all the way up to 4 cc's per kilogram per percent burn in the most popular formula. And finally, you may notice that colloid, principally in the form of plasma, was a part of early resuscitation formulas. And then with the Parkland and modified Brook formulas in the 1960s and 70s, it dropped off the list for the first 24 hours and actually got moved to the second 24 hours. So there's a gradual away from the use of colloid during the first 24 hours. In conclusion, we can say that there is wide variability in the amounts of fluid which is programmed for use during the 24 hours, which begs the issue really of what formula is the right one. So considering that there are hazards associated with delayed resuscitation or with under or no resuscitation, what about over resuscitation? So over a period of about 30 years since publication of the Parkland formula in 1968, the 4 cc's per kilogram per percent burn formula, there was the gradual recognition of a number of serious complications of over-resuscitation. And Dr. reflected in this editorial that adequate resuscitation appeared to have been replaced by fluid creep, in the apparent belief that if some fluid is good, lots of will be even better, and that the consequences of fluid can be life-threatening. And he was speaking there about abdominal compartment syndrome, first a description of that by Ivy and colleagues. This is an example of a patient who had about 85% TBSA burns. He developed abdominal compartment syndrome because he received a massive fluid resuscitation in response to hypotension and low urine output. That resulted in the need for a decompressive laparotomy. It's a bag to maintain abdominal contents. And finally, the patient succumbed several days later to overwhelming multiple system organ failure. And this is a typical course for a patient with abdominal compartment syndrome in the setting of severe burns. This condition has a very high mortality. But we also see other types of compartment syndromes, problems with cerebral edema, pulmonary and airway edema, gastrointestinal dysfunction, delayed healing, and impaired function, especially in the hands. So these are all complications of over-resuscitation. Let's talk about the abdominal compartment syndrome for a moment. So Ivy and colleagues cc's per kilogram during the first 24 hours post-burn. And as you, it's kind of a rough estimate of what places patients at increased risk. But we now call this the Ivy index, and we strive at all costs, at almost all costs, to avoid exceeding this volume during the first 24 hours because of the high risk associated with the syndrome or with its treatment by means of decompressive laparotomy. What about extremity compartment syndrome? So extremity compartment syndrome can certainly occur in burn patients with injuries of the extremities. for example, in the setting of delayed escharotomy, but it is also true that a true compartment syndrome can occur in a patient who receives simply a massive fluid resuscitation and develops a lot of edema beneath the investing fascia. And that can occur in either burned or in unburned extremities. Let's say the most common problem that we see nowadays actually is loss of pulses due to something like an arterial injury from catheter placement. And we certainly see problems with extravasation or splinting and positioning errors. Notice that in this early study by Sheridan and colleagues that large volume fluid resuscitation, 5.75 cc's per kilogram per percent burn, was common. Here you see another example of extremity compartment syndrome. In this study from our center, there were 7 patients with lower extremity fasciotomies in unburned legs, mean burn size of 45%, mean resuscitation volume of 6.9, again, quite high. And none of the outcomes are good, with 2 deaths and 3 major amputations. What about orbital compartment syndrome? So actually, this is pretty common. It can be the result of either massive resuscitation or it can be the result of simply deep facial burns. This is easily treated. It's diagnosed by measuring intraocular pressure at the bedside, and it responds well to lateral canthotomy and cantholysis, which is pretty easy to do. In our center, usually the ophthalmologist does it. But the point I'd like to make here is that, and I'm sorry for automatic advancement of these slides, the point I'd like to make here is that this problem occurs not just in big burns with big resuscitations, but it can also occur early on, meaning within a couple of hours, in patients who have isolated full thickness burns of the face. So we consult ophthalmology early to measure pressures. What about cerebral edema? So this is more suspected than frequently diagnosed. We know that there are long-term sequelae, neuropsychological sequelae of burn injury, but the cause is somewhat obscure at this point in time. This is one study that was done in humans in which they placed epidural ICP monitors in 32 patients with large burns but no head injury. And that's a pretty impressive study design. But what they noticed was that the intracranial pressure peak was 31 millimeters of mercury, and it peaked on average on day 2 post-burn. They also noticed that cerebral perfusion and intracranial pressure were both associated with survival. Now, what's the applicability or what's the basis for these observations? There is indeed a good deal of animal evidence that extensive thermal injury does cause inflammation and damage to the blood-brain barrier, which suggests that we should be careful about how we resuscitate patients. And certainly the patients with traumatic brain injury. And we do have some of those, particularly in a military, but also civilian trauma setting, would be at special risk for a post-burn cerebral edema. Now, this study from our institute, when we were taking care of both pediatric and adult patients, showed that children were at increased risk for requiring intubation, even in the absence of any inhalation injury, simply based on young age and extensive burns. And so, and this was probably due to the small airway of the child, as well as the systemic effects of edema that occur in the patient with extensive burns. You know, edema is a problem, as you can tell from this discussion, which occurs not just in burned areas, but also in unburned areas, particularly in burn size greater than 20%. So if you take this patient here, we don't even know if this patient had smoke inhalation injury, but massive edema of the face, the upper airway, the tongue, the lips, all make this patient's endotracheal intubation, both mandatory and potentially difficult. What about the wounds? So it is commonly recognized and believed that burn wound edema causes decreased perfusion of the burn wound and leads to what we call burn wound progression, which means that a partial thickness burn will then go on to become a full thickness burn at the end of the resuscitation period. To be sure, there are multiple other factors which could contribute to burn wound progression, to include inflammation, as well as a hypercoagulable state that impairs perfusion of the wound, and finally, poor perfusion due to burn shock. But edema alone is thought to impair perfusion, and this has been demonstrated, for example, in this animal study here, in which rat cremaster muscle PO2 was shown to decrease in edematous areas. And this really corroborates a sense that I have that patients who are edematous and who have massive burns are at higher risk of not healing their wounds well and of not taking skin grafts. So edema does make a difference in wound healing, I do believe. Here's a study in which the VAC device, negative pressure wound therapy, was used to remove edema from one hand, and then the other hand was treated conventionally. And if you look at the pictures on the right, you see an increase in perfusion by indocyanine green imaging after 3 days of VAC therapy. And this doesn't prove that edema causes poor perfusion, but it does suggest that by removing edema with a VAC device, you can help improve perfusion. Again, arguing that too much edema in a burn wound is not good for wound perfusion. In our institute, we studied whether wound healing and wound closure is associated with survival. And so we were able to distinguish between two sets of patients: those who went on to heal their wounds and those who had failure to achieve wound healing. And after a certain amount of time in the hospital, you go on to die with open wounds, if not in some cases because of open wounds and the sustained inflammatory process and risk of wound infection that come from having open wounds. So indeed, at about 21 days, if you haven't achieved substantial wound closure, you are en route to die. From the standpoint of fluid resuscitation, what this means is that you can distinguish between people who heal their wounds and those who do not, based in part on how much fluid they receive during the first 24 hours, which reinforces the concept that early resuscitation factors influence wound healing, which is essential to survival and successful discharge from the hospital. So resuscitation indeed does matter to ultimate outcome. So if we agree that under resuscitation is bad, over resuscitation may be worse, what are some of the causes of over resuscitation? So first of all, I think there are probably human factors, and I think that fluid resuscitation is a difficult process. Close attention. Secondly, the choice of resuscitation formula, and specifically 2 versus 4 cc's per kilogram per percent burn, probably matters. Over resuscitation at the beginning of the burn shock period can damage the endothelial glycocalyx. And finally, the use of drugs like opioids can reduce compensatory mechanisms, of course, and then cause us to give more fluids. So in this study here, we found nobody has ever done prospective studies of human decision making during burn shock resuscitation. And I think that's actually a rather interesting study to do, although hard to design. But what we showed here in this retrospective study of resuscitation practice in our unit was that the team was more likely to increase the lactated bringers rate if the urine output was low than it was to decrease the LR rate if the urine output was high. And I don't know what that's called, but I think it's, we're in Texas here, so maybe we could call it the more is better cognitive bias. Thus, escalation appears more likely than de-escalation or de-resuscitation. In this study by Kevin Chung, we took advantage of the fact that we published a clinical practice guideline for use during the recent wars in Iraq and Afghanistan, in which we said that providers could either resuscitate with 2 cc's or with 4 cc's per kilogram per percent burn. And so some chose 2 and some chose 4. And there was no intent here to do a randomized controlled trial. And it wasn't a trial, but it allowed us to compare these 2 strategies retrospectively. And we found 2 things. Number one, we found that patients who got started on 2 got more than 2, actually just under 4. And those who got started on 4 got just under 6. So with that, we also showed, though, that there was no difference in mortality or other sort of outcome measures. The conclusion here, though, is that starting on a certain formula is only a starting point, and that the resuscitation has to be adjusted from there. And that's a common theme, regardless of what formula you are using. Don't be surprised if you have to adjust upwards. And therefore, what we do is we choose a lower starting point. This is another study, and there are many like it that look at actual practice. Baxter, in publishing the Parkland formula in 1968, the 4 cc formula said that 12% would require more than 4.3 cc's per kilogram per percent burn. But these authors in the late 90s, demonstrated that they got actually 58% of patients received more than that number. So over time, you know, it would appear that the actual practice was different from the actual publication. And indeed, there does appear to be something called fluid creep over the last 30 to 40 years. There was a large multi-center trial called the GLUE grant, which studied trauma in burn patients. In the burn group in 2007, they studied 72 patients, and they categorized these patients into a group of 250 cc's per kilogram or less, which ACS, adrenal compartment syndrome risk, goes up. They found that death was more common in the large volume group, as well as trends towards increased multiple system organ failure and ARDS, and increased risk of bloodstream infections and pneumonia. Now, interestingly, and notice how they're categorizing these patients in mLs per kilogram. More recently, in 2016, the same group from the GLUE grant published a larger number of patients, 330 patients, but here they categorized them according to cc's per kilogram per percent burn. And they found that patients who got less than 4 to 6 cc's per kilogram per percent burn, what they called the restrictive group, had increased risk of AKI, acute kidney injury. Now, I'm going to say that I don't like the way they categorize these patients, because when we're talking about risks of resuscitation, the really important number is the cc's per kilogram, not the cc's per kilogram per percent burn. And like I said before, we really try to avoid 250 cc's per kilogram during the first 24 hours. And that doesn't matter what formula we chose to start out with. The glycocalyx. So now we understand a little bit more about the structure of the endothelium and the role of the glycocalyx in defending microvascular permeability as well as intravascular and controlling inflammation at the microvascular level. And there are multiple factors that are present during burn shock that can affect the glycocalyx, and you see them here. Certainly ischemia, reperfusion, hypoxia, oxidative stress, absolutely. Hyperglycemia present in many of our patients, civilian patients in particular. Hypervolemia, catecholamines, absolutely. And later in the hospital stay, hemorrhage surgeries we do, and sepsis. All of these factors are in play in patients with major burns. There are some data to suggest that burn patients, like trauma patients, we are now beginning to realize do experience injury to the endothelial glycocalyx during burn shock and resuscitation. In this study from Japan of patients with sort of moderate to large burns, they adjusted for age, sex, TBSA, and inhalation injury, and they found that Syndekin-1, which is a predictor of fluid resuscitation volume, as well as of compartment syndromes, which means to me that large volume fluid resuscitation goes along with, whether it's a cause or an, I don't know, of endothelial damage. Dr. Schupp and colleagues at the Washington Hospital Center, Georgetown University, Washington, D.C., have studied the so-called endotheliopathy of burns in rodent models. And in this study, they compared resuscitation with lactated ringers or LR plus FFP, and they found that FFP decreased Evans blue dye extravasation in large burns. That is to say that it appeared to have a protective effect on the endothelium, which has implications for a sort of resuscitation strategy going forward. Now, this concept of opioid creep is that over time, our use of narcotics has gone up. And of course, in burn patients, we want to control pain, but perhaps heavy use of narcotics is not the best way to do that, particularly during the burn shock period. Remarkably, this study from Harborview in Seattle showed that there was a huge increase in the use of opioid equivalents during the first 24 hours, and that it was associated with a huge increase in resuscitation volume in age, sex, and burn size matched controls. So we should be careful about how we provide analgesia and sedation to these patients during burn shock, and that has special impact if we have to take the patients to the operating room. Now, how can we optimize? So we've talked about burn shock, a little bit about under resuscitation, a lot about over resuscitation, but how can we optimize and specifically avoid the risk of over resuscitation? So first of all, I think we should start low and we should go slow. By start low, I mean that we should use the 2 cc per kilogram per percent burn formula rather than the more popular Parkland formula. And in fact, that is represented in the American Burn Association's Advanced Burn Life Support Program now as the recommended formula for resuscitation, the 2 cc formula. And we should go slow and avoid boluses. That doesn't mean never give a bolus. A patient comes in and is profoundly hypotensive, they're going to get a bolus. But the average patient does not require a bolus, but rather gradual changes and sustained changes, avoiding a yo-yo effect in the treatment of burn shock. We'll talk about colloid rescue, decision support, and situational awareness. We'll talk about some other indicators, renal replacement therapy, pressors, narcotics avoidance, and some pharmacologic adjuncts. So colloid rescue is the concept that if I start my resuscitation, as we do nowadays with a crystalloid solution, we need to be prepared to add a colloid. And as I said before, the modern burn formulas, whether the Parkland or the modified percent albumin, starting at the 24th hour post-burn. But if the patient is not doing well, it is okay to start that colloid earlier. What is earlier? Earlier is probably sometime around the 8th to 12th hour post-burn. How do you determine what we mean by earlier? Well, earlier means really, not doing well really means, are we on target? Are we headed towards a 250 cc per kilogram resuscitation during the first 24 hours? That's how we define risk of over resuscitation. We're trying to extrapolate our current infusion rate towards the 24th hour. And we're also trying to avoid a continuous rate of 2 liters per hour, and we'll do so at almost any cost. Dr. Saffel, in this widely used protocol, uses a somewhat more complicated approach. Either way, this concept is called colloid rescue. What about simply improving situational awareness? The Joint Theater Trauma System clinical practice guidelines are available online, and the Burn CPG is one of the most popular ones. These CPGs were developed for use during the recent wars in Iraq and Afghanistan, and they are still available for download, and they continue to be updated. So if you'd like to take a look at those, please go to the Joint Theater Trauma System, JTS, Joint Trauma System website, and you can download them there. In this study by Ennis and colleagues from our institute, we published a CPG, and we also asked deployed providers on the battlefield to fill out a paper flow sheet, and for that flow sheet to accompany the patient as the patient went through all the stages of care as they go from the battlefield to combat support hospital to en route to Landstuhl, Germany, arrival at Landstuhl, and then ultimately back to the United States. And this simple intervention improved our experience with the combined endpoint of abdominal compartment syndrome and mortality, a relatively low-tech way of improving situational awareness and improving handoffs across a pretty strenuous and complicated handoff process. We also developed a computerized decision support system, which provides and is intended to provide improved situational awareness to bedside providers so that they're aware of how much fluid has been given, how much is being given now, and what the urine output is. In addition, the system provides recommendations in terms of changing the fluid resuscitation rate with the goal of achieving a urine output target of 30 to 50 cc's per hour. If we are on target, if we are on course not to reach that 30 to 50 cc's per hour urine output target, then the program will tell you to go up on the fluid infusion rate. But if, on the other hand, we are on course to go over the target and have too much urine output, the program will tell you to go down on the lactated Ringer's rate. And thus it is in part intended to overcome that reluctance on providers' part to de-escalate resuscitation. And with that, we demonstrated a decrease in resuscitation volumes in the 24 hours and 48 hours post-burn compared to recent historic controls. And this has become our usual practice at the burn center. So in conclusion, over-resuscitation causes numerous complications in burn care and can and must be avoided. And some of those complications include compartment syndromes, pulmonary and airway edema, cerebral edema, problems with the wounds, problems with the hands. Successful burn resuscitation, however, can be performed if you successfully navigate between over and under resuscitation. So the key to successful resuscitation is giving enough fluid, just enough, not too much, a state which we would call permissive hypovolemia, and that's our real target for the first 24 hours post-burn. I hope this information has been helpful, and I'll be happy to take any questions during the break. I'm sorry for my automatic slide advances, and I wish I was in Chicago, but I'm happy to join you here virtually. Thanks.
Lee, thank you very much for your expert presentation and also for bringing us slightly back on time. So that was perfect. Just as a reminder, before I introduce the next presenter, to submit any questions you may have for our panelists or their content in the Q&A portal. Lee, can I ask you to stop sharing your screen, please? Lovely. Okay, so our next presenter is Dr. Christian Diaz, who's an associate professor and vice chair of clinical affairs at the University of Miami at the Ryder Hospital. And according to one of our attendees, is the nicest person she knows. Christian, over to you, sir.
Well, she's definitely the nicest person for saying that, but thank you, Jeff, for that great introduction. Let me see if I can, I was worried you're gonna mess up the PowerPoint, right? Let's see. Let's make sure. Is that a good size? Does it look small?
A little small.
Okay.
Perfect.
How does it look there? Good?
Not too big.
All right. Oh, hold on. Let me try to make it smaller here for a second.
Yeah, good.
There, we're good. Okay. Let me see if I can go back. All right, looks okay?
No, we've lost the image.
Do you see just the presentation or you see the whole thing?
I can see the presentation in that view.
Okay, so does it look good now?
Yes.
Okay, perfect. All right, sorry, it's just trying to obviously get your comments and everything in view. So as long as it works there, then I hope that we're doing well. Okay. All right, great. So if it looks good, then I'll start. And again, thank you very much, Jeff, for that introduction. This presentation is devoted to penetrating neck traumatic injuries. Although these injuries are not very common, I find this to be a fascinating topic because their management is interesting and debatable. The second reason to discuss penetrating neck injury is due to the urgency of these situations. Therefore, having a plan ahead of time will help us be prepared when you do encounter a patient with penetrating neck trauma. I do not have any printed disclosures for this talk. Traumatic injuries kill more than 5 million people annually, and millions more suffer from the consequences of injuries. Almost 1 out of every 10 deaths in the world is a result of injury. In the US, trauma is the leading cause of death in people of all ages following heart disease and cancer, and is the leading cause of death in children and adults up to 44 years of age. The opioid epidemic is classified as poison. Therefore, it's a totally different classification. Although few anesthesiologists care exclusively for trauma patients, most anesthesiologists will care for trauma patients at one time or another in their clinical practice. Active participation of anesthesiologists in the care of the most severely injured trauma patients is essential for improved outcome and represents another opportunity to highlight the anesthesiologist's role as a perioperative physician. So that's where I am actually right now. I call it work. My wife says this is probably actually my house. The Ryder Trauma Center is at the University of Miami-Jackson Memorial Medical Center. It is an adult and pediatric level 1 center in Miami, and one of the freestanding hospitals in the US dedicated exclusively to the care of trauma patients. For the past 20 years, the Ryder Trauma Center has also served as the US Army Trauma Training Center, where all forward surgical teams deployed to Iraq and Afghanistan have been trained since 9/11, and since then we've also had White House personnel and other branches. With Miami being a hotbed for everything, presidential politics, zombie attacks, we keep ourselves pretty busy. Our annual caseload is around 4,500, with 70% being blunt injury, 25% penetrating, and around 5% burns. About 40% of the patients arrive via helicopter and the others by ground ambulance. At the end of the discussion, the goals are to recognize the 3 neck zone classifications, discuss the mechanisms and types of injuries associated with penetrating neck trauma. It is important to acknowledge that blunt neck injuries do occur, and although their airway management is similar, their surgical workup is different. I will discuss the type of injuries and will divide them into 4 sections. Lastly, I will discuss the possible approaches to airway management and discuss my preferences according to our experiences here at the Ryder Trauma Center. So as we know, neck injuries are broken down to 3 zones. Zone 1 is the area between the clavicles and the cricoid cartilage, with the highest mortality with incidence around 10%. Zone 2 is the area between the cricoid cartilage and the angle of the mandible, and it is the most common, with around 80% of injuries occurring there. And Zone 3 is the area between the angle of the mandible and the base of the skull. And those are the most rare, and those are less than 10% of incidence. So a little bit of history lesson. In Homer's Iliad is described how Achilles killed Hector with 1 blow to the neck. It was written that this was the shorter way to death. And even back then, it was known that a zone 1 injury was pretty lethal. Hopefully this works well, that we've actually have live footage of one of the battles. So in that opening scene, we could see how a zone 1 injury made things go pretty quickly. The majority of penetrating neck trauma is a result of stabbings and gunshot wounds. Examples of low velocity injuries are handguns and shotgun wounds. High velocity injuries are a result of high power rifles, and these have 60 times more energy than handguns and shotguns at a close range. High velocity injuries carry the greatest mortality rate. And I do want everyone to appreciate that the kinetic energy from the projectile is what poses the greatest harm. One of my colleagues here in the trauma center always says a story of, we had a very elegant lecture on kinetic energy and damage to tissues, very scientific lecture, kinetic forces, lots of physics involved. And at the end of the lecture, the audience just kept walking up to him going, so what gun should I buy? Stabbing injuries always grab our attention. Many times they're very bloody, they're gruesome, and even still in the patient many times when they arrive. Although these are very concerning, please remember the previous table and their mortality compared to gunshot wounds. For example, this patient lived. This patient was not as fortunate. There's a gunshot wound to the left neck at the level of zone 2. Although this patient was initially asymptomatic, he rapidly developed respiratory distress from an expanding neck hematoma and died within 20 minutes of OR arrival from a carotid transection and a right tension pneumothorax. So let's move on a little bit to findings. Although penetrating neck injuries to the airway are frequently obvious and dramatic in their presentation, the entry wounds and the presenting symptoms are poor predictors of the extent of injury. The following are considered hard findings, and we will go over management of these patients with respect to the physical findings later. Dyspnea and subcutaneous emphysema are present in almost all penetrating laryngeal tracheal injuries. A sucking neck wound and progressive hypoxemia are pathognomonic for major laryngeal tracheal laceration and avulsion. Further, loss of palpable landmarks in the thyroid or cricoid cartilage is a very specific finding for airway injury, although not very sensitive, as a normal palpation certainly does not rule out a significant injury. Any patient with signs of shock, active bleeding, or pulsating hematomas warrants immediate control of the airway and surgical exploration, as a major vascular injury is highly suspected. Soft findings are as follows. Dysphonia may occur in patients with recurrent laryngeal nerve injury, vocal cord injury, or partial tracheal avulsion. This sign, however, may be absent in up to 2/3 of the patients. Mild to moderate hemoptysis immediately after trauma usually stops if the injury is limited to the larynx or trachea, but continues in the presence of associated vascular injuries. Chest and soft tissue neck x-rays provide valuable information and should be obtained in all stable patients. We will get in greater detail soon, but if ever in doubt, intubate. I've seen a patient with a zone 2 injury seem perfectly stable awaiting CT scan, one cough, and suddenly her neck rapidly started expanding from a developing hematoma. If I wasn't standing right next to her when this occurred, we probably wouldn't have enough time to secure the airway before it was compromised. We said we'll divide the injuries, so we'll divide them into 4 groups, which are in these subheadings: airway, vascular, neurologic, and esophageal, and we'll discuss them individually. So airway injuries, penetrating injury to the larynx and the cervical trachea is rare compared to injuries to other structures of the neck. One explanation of why they're rare is that the majority of the victims who sustain airway injuries die before they reach medical care. Of those patients who do survive to reach tertiary care, 21% die within the first 2 hours of admission. Airway obstruction after penetrating neck trauma can occur by several mechanisms: direct injury to the larynx or the trachea, hematoma causing external pressure, displacement of soft tissue into the airway, aspiration of blood, gastric contents, or foreign bodies, and bilateral severance of the vagus, recurrent laryngeal, superior laryngeal, and or the hypoglossal nerves. These can produce obstruction by either facilitating aspiration or by causing abductor paralysis of the vocal cords. Let's talk a little bit about vascular injuries. Diagnosis of a vascular injury in the presence of a specific physical finding such as hematoma, external or internal hemorrhage, distal pulse, or blood pressure deficit is usually pretty obvious. Although a large hematoma with asymmetry of the neck is a reliable indicator of significant vascular injury and airway compression, its absence does not exclude the possibility of an airway compromise. If a hematoma is present, early tracheal intubation is carried out prophylactically in order to avoid possible airway compromise by an expanding hematoma, as I mentioned earlier. In addition to chest and soft tissue neck x-rays, CT angio or angiography are an important diagnostic test, especially for the injuries located in zone 1 and zone 3. Case we had here, 50-year-old woman came in, Glasgow 15, stating she had tripped while carrying a pane of glass. She had a small piece of glass protruding above her clavicle. She was 100% stable, no shortness of breath, no complaints at all. She was taken to CT angio, where she started to show some signs of hypotension and shock, and there she was immediately intubated and resuscitated. However, her injury proved to be devastating, and this patient died due to her zone 1 vascular injury. The spinal cord, phrenic nerves, brachial plexus, and autonomic nerves may be injured individually or in combination. Cervical spine injury is usually the result of gunshot wounds and is uncommon after stab wounds. Neurologic recovery in the patients with complete lesions is uncommon. This is a GSW to the neck, C3 fracture with obviously the vertebral canal shattered. Esophageal injuries. The key to successful treatment of penetrating esophageal injuries is an early diagnosis. A delay in diagnosis longer than 12 hours significantly increases mortality. Mediastinitis is the most devastating complication of undetected esophageal perforation. The signs and symptoms of esophageal perforation are unreliable. Retropharyngeal or paravertebral air on the cervical X-ray should raise a suspicion of esophageal or hypopharyngeal perforation. Uncooperative patients and those in whom the barium swallow study is equivocal will require rigid esophagoscopy under general anesthesia. I don't have a recent slide, but this is an older picture of status post GSW above the left clavicle. This patient had an esophagram, which, it was equivocal, contrast aspiration, possibly taken to the OR for an esophageal exploration. Airway was secured via rapid sequence induction and intubated on the first attempt under direct laryngoscopy. Fiber optic visualization of the ET tube and the trachea did not show an injury. Through neck exploration, though, an anterior esophageal wound was repaired and a through and through tracheal injury was found. Why couldn't it be seen after the intubation? Because it was at the level of where the ET2 cuff was. Therefore, the ET2 cuff was advanced distal to the wound, and therefore then the posterior tracheal injury was repaired and a tracheostomy tube was placed through the anterior wound. We can go quickly through the surgical management with respect to physical findings. Hard findings, as we discussed, are they present airway compromise, shock or active bleeding, pulsatile hematoma, or sub-Q air? Yes, then the patient needs to go to the operating room. If the hard findings are not present, well, are there soft findings? Dysphagia, dysphonia, hemoptysis, or a wide mediastinum? If there isn't, then you observe. So the middle part is obviously no hard findings, but we have some soft findings. Depending on what you might think, or where your suspicions are, CT angio, looking down with an endoscope, EGD, is an injury suspected. If an injury is suspected after workup, obviously the patient will go to the operating room. If not, the patient can be continued to be observed. Penetration of platysmal muscle is often used as a distinction between superficial and deep. A zone 1 may require medium sternotomy and a clavicle resection. A zone 3 may require disarticulation of the mandible or resection of the base of the skull. Definitely, angiography has definitely helped a lot more with zone 3 diagnoses and treatments. And in the presence of hard signs, it has been found that CT did not add much useful information. However, a high resolution CT angio does have the ability to dictate bullet trajectory. Angiography is still considered the gold standard. However, the disadvantage is a large amount of contrast required with CTA and the dependence on the skill of the operator. Emergent endovascular intervention may prove beneficial in zone 2 injuries for carotid stenting, or as I mentioned, in zone 3 vascular injuries, as surgical access is usually very difficult. In the presence of time, I decreased I took away some of the studies There were pretty older studies regarding trying to see what was the best method of intubation. We can discuss here a little bit of that. As with any other form of trauma, airway management remains the first priority of resuscitation. And there is no uniform agreement as the preferred method of airway management in patients with penetrating neck injuries. The small number of patients included in most series, the prolonged periods over which large series were reviewed, and the diverse nature of these injuries preclude formulating a single method of choice. Most authors agree that blind intubation methods, such as a blind nasal tracheal, should not be used in these patients because further injury or complete airway obstruction may be induced. So therefore, there is no one-size-fits-all strategy. So because there isn't, then we're going to try to go and see, you know, how we can decide how we're going to tackle these injuries. And not all neck injuries are created equal. So let's talk a little bit about, we said, airway management. Factors that determine which method of airway management is selected for a particular patient include the urgency of the situation, patient cooperation, type of injury, and the presence of significant bleeding or airway obstruction. So at the Ryder Trauma Center, patients with penetrating neck injuries who require airway intervention undergo endotracheal intubation by one of the following methods: either an awake endoscopic intubation, a rapid sequence endoscopic intubation, and we'll discuss that, a rapid sequence induction and intubation, or an awake oral tracheal intubation. Awake endoscopic intubation is the safest method for most patients and should be considered in all cooperative patients with suspected airway injury. This method allows evaluation of the injuries at or below the glottis and positioning of an endotracheal tube distal to the injury. However, an awake endoscopic intubation is usually not possible in combative patients or when immediate airway access is required, for example, in a moribund patient. A rapid sequence endoscopic intubation is a technique which may be used in combative patients who otherwise do not appear difficult to intubate. A standard rapid sequence induction intubation is used for patients that have a normal anatomy, minimal risk for airway injury, for example, a SLAS injury behind the sternocleidomastoid, and they might have a high risk for bleeding or coughing or straining, where having them paralyzed is more advantageous than trying to do an awake and like we said, possibly they cough, they have some kind of straining, and therefore now you just made a vascular injury worse. One common question that we get is, and especially now with video laryngoscopy, is, well, why not do video laryngoscopy on all these patients? And again, not all injuries are created equal. However, we have to keep in mind that video laryngoscopy lets us know what is there at the level of the cords and above, but we're still going pretty blind at below the level of the cords with video laryngoscopy. So if I have a patient who comes in with a penetrating neck injury, and the first thing I do is usually try to feel for sub-Q air. There's a large amount of sub-Q air, and I have a high suspicion of a tracheal injury. Using a video laryngoscopy doesn't really make me feel better because I don't know it's not gonna let me see below the level of cords. Back to an awake oral tracheal intubation is the most expeditious approach when an immediate control of the airway is required in a moribund or an aptic patient, or in cases of massive upper airway bleeding. If any of the above intubation methods fail, then a surgical airway should be immediately established. A cricothyroidotomy may be chosen if the injury is above the level of the cricothyroid membrane, for example, a zone 3 injury. However, this procedure is not helpful in patients with injuries below this level, for example, zone 1. If this situation, a zone 1 airway injury, this is one situation in which a tracheostomy is necessary. It must be performed below the site of the injury pertaining to the airway. Patients with an overt airway injury communicating with the skin can be rapidly intubated through the wound. So as we mentioned, awake endoscopic intubation is the safest method for most patients and should be considered in all key cooperative patients with a suspected airway injury. This method allows evaluation of injuries at or below the glottis and positioning of an endotracheal tube distal to the injury. However, awake endoscopic intubation is usually not possible in combative patients or when immediate airway access is required. So I have an example of a gentleman who, so we get a slide to work. This is a gentleman who experienced a gunshot wound to zone 2. He was awake, he was cooperative, albeit anxious. The hole was too small for a through the wound intubation, and an attempt may have just caused bleeding or further damage. After topicalization, we performed an awake fiber optic. Back then, we had fiber optics, not just endoscope. Fiber optic intubation for both the evaluation of the extent of the tracheal damage and for airway management.
And a single laceration.
So that's, I apologize. So that's right below the level of the cords. And I'll give it to you one more time. So we're seeing right after the vocal cords, you see, obviously see the tracheal ring, see the trachea, going down, and then that's the injury anterior.
And a single laceration. It's only one laceration. Yeah, it's about 3.5 long, and it's usually small. It's probably 5.5 long. All right, no problem. How much better do you have?
So I mentioned rapid sequence endoscopic intubation technique may be used in patients who are combative or otherwise do not appear difficult to intubate. In this technique, a rapid sequence anesthetic induction is followed by standard laryngoscopy and insertion of a bronchoscope through the larynx to rapidly evaluate the presence of injury or blood below the vocal cords. The bronchoscope tip is placed distal to the injury, and the endotracheal tube is then introduced over the endoscope. The cuff of the endotracheal tube should be positioned below the injury to prevent air leak and enlargement of the laceration. The equipment must be immediately available. Bronchoscope, have obviously a screen, your monitor, and an airway cart. Now, this is an example of how a rapid sequence fiber optic intubation would be used for diagnostic purposes and for airway control. This is not a patient. This patient did not have a penetrating neck injury. This was just done for demonstration. In a patient who does have penetrating neck injury, obviously cricoid pressure would not be used as we're doing it in this patient. So the member of the team doing direct laryngoscopy is not looking at the scope. They're just going to look at the airway. You see, they're not looking at the monitor at all. Your surgical colleagues can be there looking, so they can as well look to see what injuries could be present and at what level. And as they keep advancing the endotracheal tube, we get a clean look of the trachea. In a patient who does have penetrating neck injury, you can see if there's blood in the airway, is any any deformity. And although it does sound cumbersome, as you can see, in a patient that you're able to pre-oxygenate as best you can, it's not a lengthy procedure. That is a technique that we use frequently here when there's a high suspicion of a tracheal injury. Again, just the thought of putting the tube in blindly past the cords is something that we really worry about. Standard rapid sequence induction intubation is used for patients that have a normal anatomy, minimal risk for airway injury, and a high risk for bleeding or coughing, a high risk for bleeding if coughing or straining occurs. An awake oral tracheal intubation is the most expeditious approach when immediate control of the airway is required in a moribund or apneic patient. If any of the above intubation methods fails, a surgical airway should be immediately established. A cricothyrotomy may be chosen if the injury is above the level of the cricothyroid membrane, for example, zone 2. However, this procedure may not be helpful in patients with injuries below that level. This is one situation in which a tracheostomy is necessary. It must be performed below the site of the injury. Patients with overt airway injury communicating with the skin can be rapidly intubated through a wound, through the open wound. Obviously, this is a patient with a through the wound intubation. This gentleman did not require topicalization. However, there are patients who are pretty awake, even with some pretty, big graphic injuries, and they can be awake, and putting the tube could be very stimulating. If just spraying some 4% lidocaine right through the open trachea can help diminish the sense of being uncomfortable when you perform the through the wound intubation. So the key point, as we're kind of mentioning, is there's no ideal method for all patients. We mentioned that the importance of having a plan is because of the urgency of situations. As we've all been there, 3 o'clock in the morning, all of a sudden, there's a gunshot wound to the neck coming in 2 minutes. The other thing to consider is patient cooperation. If a patient is cooperative, then awake endoscopic is a huge tool to at least not just for if the airway needs to be secured, but also for diagnosis. CT scans are great, but having our surgical colleagues be able to see the injuries with an endoscope, especially with the patient spontaneously breathing, can be very helpful. Type of injury, as we mentioned, is also very important, what level it is, and the presence of bleeding or airway obstruction. And the take-home method, as I pretty much said, was, intubating endoscopes are a valuable aid for evaluation and for intubation. And thank you very much, and I appreciate your time and the invitation.
Thank you, Christian. If I could ask all of the panelists, Nadav and Lee, to put on their screens, and anybody else from the panel who would like to ask some questions. So, Q&A portal, here we go. I think some of them have already been answered, but in case you haven't been specifically looking at the responses that Lee has put in to some of your questions, we'll just ask them again for completeness. So there was one question presented by Dr. Moss. What modalities, this is to Lee, by the way, what modalities are you using for pain control in burn patients if you are limiting opioids?
Right, so thanks for that question. Typically, a continuous infusion of ketamine it would be commonly given in our ICU. We are attempting to limit opioids, but they remain, they're used in essentially all ICU patients in our burn center. So we're not eliminating opioids. And for some reason, we have a ketamine shortage right now, which obviously is affecting our strategy. Over.
Thank you. This is a question for Nadav from Josh Sattenfield. I've heard that fetal monitoring can be useful for resuscitation in pregnant trauma patients. Is that not true, or does it just get in the way?
First of all, thanks for the question. Dr. Sappenfield published a comprehensive review about this topic I think back in 2016. Very interesting, but basically fetal heart rate is a very useful tool to discover a placental abruption. That's the major use for it and other pregnancy-related injuries. Now, it has a very, very good negative predictive value for those injuries, for abruptio placenta. I am aware that there are recommendations to use fetal heart rate as a tool to monitor maternal hypovolemia. And I even know that there's been recommendation back in 2010 by the Eastern Society of Surgery and Trauma to do so. I am not familiar with any works that tested the sensitivity of such a method over other more traditional ways to monitor maternal well-being.
Okay, thank you. Christian, this one's just popped up. What sedation, if any, do you use for your awake intubations?
So my attempt for awake are awake, correct. They're not obtunded intubations or awake intubations. Now, that being said, if, usually dexmedetomidine is, seems to be the choice that we most use. Versed disinhibitors people sometimes, and now they're just not cooperative at all, even one. Anything that decreases respiratory depression is obviously something we don't like to do. In my experience, I will say, if patients know that they're in trouble, they know that, and when you explain to them, look, we're going to get through this, as long as you have good topicalization, you should be able to do it awake. And many times, and we've all been there, many times sedation is the crutch for poor topicalization. And that can happen for many reasons. It can happen because you didn't have enough time. We get called frequently from the ER for angioedemas, and they don't call us when they show up. They call us when they've already tried everything and now the airway's about to close. So time is usually of the essence. So we normally do not use. If I had to use, dexmedetomidine is probably my go-to.
Thank you. This is to Dr. Cancio from Balbi Lopez. You've answered it in the chat, but I'll ask it again for the rest of the panel, for the rest of the delegates. You stated burn resuscitation is always fraught with under versus over resuscitation, and identifying where we are in the ICU can be difficult. Do you perform any routine abdominal pressure monitoring to help identify compartment syndrome earlier, or as a way to identify reduced renal perfusion earlier?
So we routinely measure bladder pressure in patients who are on course to exceed the IV index of 250 cc's per kilogram during the first 24 hours. And but we don't want to start that measurement at 250 cc's. We really like to start at around 200 cc's per kilogram, whenever that might occur. If we find that bladder pressure is elevated, and we'll tolerate something in the teens, but once we get into the 20s and certainly the mid-20s, we start to worry a lot. And at that point, I'm going to start pulling out all the stops in order to, number one, try to relax the abdomen, and number two, reduce my fluid infusion rates. And finally, there are interventions short of a laparotomy to relieve increased intra-abdominal pressure, which I would do before doing a laparotomy, unless it was an emergency with the patient in arrest or near arrest conditions. And the number one thing I would do there is, first of all, determine whether the patient needs an abdominal escharotomy for tight, full thickness burns of the abdomen. And sometimes that will be quite helpful. And the second thing I would do is I would consider placing a catheter into the peritoneal cavity in order to remove any accumulated fluid there. Nowadays, certainly placing an ultrasound on the abdomen to verify that that would be helpful. And what we can do then is we can simply secure that catheter to the abdominal wall and hook it up to a bottle for continuous drainage. With that, we've been able to avoid laparotomy in some patients. Over.
Thank you. I've got a question for Christian. So spectacular videos, by the way.
Yes.
Everybody appreciated those. Um, so looking specifically at patients that you would consider intubating through the wound on the anterior neck, how do you mitigate the risk of completing a partial tracheal resection when you push your tube through the hole in the neck? Because there's nothing providing opposing traction when you're pushing down, and pop, trachea completely transects.
That's a great point. That's a great point. And I am very lucky where I work, where you have so many good resources and people around you at all times. I'm not as cavalier to do it probably if I didn't have a surgical colleague right next to me, and that we both look and go, okay, this is probably the best way of doing it. Most patients who do have a defect large enough through the wound, they're breathing, and so it's, I mean, obviously this is an emergent thing we need to do, but you do have, I don't just go and obviously just do it without it. It needs to be pretty obvious that there's a big hole there, and there's not, like you said, like maybe a flap or something that you can cause more damage. And actually in the picture I did show, what we had done, and actually that would have been another good video to show, is we did it through the wound. The patient was then induced. Then we went and we intubated with a scope above, just so they can fix the defect with a tube through the trachea. So absolutely, I guess my point would be, when you're doing it, make sure you have a good surgical colleague right next to you, and making sure you both agree this is probably the best way of doing it. Thank you.
Nadav, questions just popped up from Dr. Varon. How do you manage the massive healthcare worker crowd, OB, peds, etc., that shows up when you have a pregnant trauma patient that's pregnant?
That's a great question. I really don't know where do they get 20 people in the middle of the night whenever there's a pregnant trauma patient. I honestly don't know where they come from. When we were in the trauma room, we usually let the trauma surgeon deal with the mess, because they are like the leaders. But once we're in the OR and they start stepping on our foot, then first we put them to work, like you talk to the blood bank, and we just give them missions. And then sometimes we have to get a little bit vocal and just get out of here. And if you really want to be there, stand in the other side of the room, but don't interrupt us. But we would just try to kind of make them work.
Just to share a scenario which happens in the military ED, for example, when we were in Afghanistan, you would have a red line. So it's only the people directly working on the patient at that time are allowed to cross the red line. If you're not invited, you stay outside, and that is extremely rigorously policed by some of the the ED charge nurses. I've got another question from Mira to Dr. Cancio. Thanks for your very comprehensive and useful information. How would you rate LR versus Plasmolite or Normasol as a resuscitation fluid in your patients?
The answer is that we don't really know, because no one has ever tested that. And certainly, I think it's fine to use Plasmolite. It's just when these formulas came out, it was the early 1950s, and I think that lactated Ringer's or Hartmann's solution was the only physiologic crystalloid solution that people knew about. So fortunately or unfortunately, we kind of have an orphan injury in this, and therefore the accumulation of data on questions like that is rather slow.
I'm going to read on. It's another one for you, Lee. But Jason, have you got anything you'd like to ask before I jump?
Yeah, I had a peripherally related question for Nadav to his talk, and that is, what are his thoughts on the use of low titer whole blood in childbearing age females, as more and more trauma centers are shifting towards the use of whole blood, and many of us are using O positive whole blood as that product?
So we actually just recently, like in the last few months, started to use those in our hospital. From what I know, there's really not a problem. There's very little, like, it actually depends on the population you work with, because the titer of the in different population is different. But apparently in Israel there's no problem with it, and so we've started using it, and so far it's working great. I really don't know what the situation is in the States, but it depends on the place you are.
What is the titer of your product you're using? The typical would be 1 to 250, for example. Some institutions are able to get as low as 1 to 50?
We're not there. We're not in 150. Probably 1-200, but I'm honestly not a specific, not specialist in this subject, but it's probably around that number. Yes.
Thank you. So
Thank you.
going back to Lee, this is another question from Dr. Lopez about, he's curious to hear your approach about looking at new Foley's to measure bladder pressure. They're using it at Irvine to look at the cardiac patients and to see if we can correlate increased abdominal pressure to decreased renal perfusion early in the post-op period. Any comments on that?
Right. So the measurement of renal perfusion is a worthwhile goal and of great interest because urine output only alone, whereas urine output is what we have immediately available to us. So recognizing that either decreased blood flow or caused by shock.
I don't know if anybody else is having a problem. You're coming in and out, Lee.
Say again?
Could you start that again? So I lost you.
Okay, we'll start over. So when we're talking about measuring abdominal compartment syndrome or bladder pressure and the effects of increased intra-abdominal pressure on renal perfusion, we have to also recognize that in the setting of burn shock, not only increased abdominal pressure, but also decreased perfusion due to hypovolemia are going to affect renal perfusion. The problem is rather complicated. The likely value of measuring bladder pressure continuously is to trace the any increases in of a large volume fluid resuscitation in order to permit earlier intervention and, for example, the things that I mentioned, but certainly to modulate the amount of fluids the patient is receiving. So I think it is a worthwhile thing to do. Correlating that to renal perfusion is also of interest, although that, like I said, will be affected by the presence of burn shock alone. Over.
Thank you. So we've had a question, Christian, posted in the chat rather than the Q&A portal. So please try and direct your questions in the Q&A. And it's from Caleb. How do you utilize CRNAs at Ryder Trauma Center?
Correct. Yeah, I was actually just typing it there, but I'll answer it here. The question was, do we utilize CRNAs? We have CRNAs that they are actually officially through the Army stationed here. And this is their official post. So when the Army forward surgical teams come and train, we at least have someone that knows the place, knows how to do a chart, knows how to take out meds to help with the training. So the CRNA we have here is through the Army, and that's their official kind of post for 3 or whatever their tour duty is.
Excellent. We also have some embedded US Army surgeons and CRNAs and nurses that joined us last year. So it's good to have them all. I agree. I think unless anybody's got any further questions they would like to ask, either as delegates or within the list of panelists, we'll just give a moment of pause. Oh, there's one just popped up. Thank you very much. Really enjoyed your presentation. Okay, ladies and gentlemen, thank you for everyone's contributions and wonderful presentations. The weekend is now yours, unless you want to continue to earn CME. We will resume with Bravo session at 10:15, which is in 22 minutes. So enjoy your comfort break. Thank you all.
Thank you.
We'll be talking a little bit about finding ultrasound correlates for different types of injuries to the heart and aorta, as well as to the lungs, as well as a technique that can be used to help look for elevated intracranial pressure in the setting of a traumatic brain injury. So to begin, we'll start a little bit with the heart and the aorta. And I know that I mentioned that this would be beyond the FAST exam, but really part of the FAST exam includes looking at the heart to assess for tamponade. So I think it is worth mentioning that there's a couple of really fine points to really drive home here. The first is that a pericardial effusion refers to the presence of fluid in the pericardial space, and that might be due to any number of different causes. But tamponade is the physiologic derangements that's associated with the pressure in that space exceeding the pressures of the cardiac chamber, causing an obstruction to appropriate filling of the cardiac chambers. So just to help drive that point home, here is an example where you can see a generous amount of fluid in the pericardial space around the heart, but as you might be able to tell, it doesn't seem like there's any very obvious impairments to filling. All the chambers of the heart, especially the ones that are closest to the probe here, which would be the right atrium and the right ventricle, look very generously filled. It does not look like there's any diastolic collapse in this example. To understand what the derangements we're looking for are, it's important to understand what the normal respiraphasic changes are. And I can forgive that many of you probably have not had to spend a lot of time thinking about this since your physiology class. But just to make sure that everybody understands it with the appropriate level of detail, with normal negative intrathoracic inspiration, you have negative intrathoracic pressure, an increase in venous return to the right side of the heart, and that increases the right-sided volumes in the right atrium and the right ventricle. That displaces the interventricular septum towards the left, and concurrently you have expansion of the pulmonary venous side. So the pulmonary blood vessels expand. That leads to a lower left atrial volume and a lower stroke volume. With the expiratory phase, all of those findings are reversed. As the lungs decrease in volume, that brings a little bit more blood back towards the left atrium. You have a decrease in venous return to the right side, and that causes a rightward displacement of the interventricular septum. And that ultimately leads to greater left atrial return and an increased stroke volume. All of those findings are still the case in tamponade with negative intrathoracic pressure. However, the findings are exaggerated, and that leads to a greater than 10 millimeter mercury difference in blood pressure that you can observe. So once again, another example or a graphic representation of what that is here. So on inspiration, increased RV volumes, and then on expiration, increased LV volumes. That leads to an increased pulse pressure. And then with tamponade, these findings are exaggerated even greater. The other findings that you might typically look for if you're placing a pre-induction arterial line, you might be able to see pulsus paradoxus, this greater than 10 millimeter mercury difference. Here they're showing in the systolic volumes, because before we had arterial lines and we had to just use sphygmomanometers, that was how pulsus paradoxus was diagnosed, by auscultating this systolic blood pressure with carot cough sounds. You may also observe electrical alternans if there's a very large amount of fluid. And here you can see that as differences in the QRS height here. This is an ultrasonographic depiction of cardiac tamponade. This abnormal septal motion or free wall of the right ventricle motion that you see here, that is due to early diastolic collapse. And in this example, the patient is definitely tachycardic, but if I pause this video and slow it down, what you might be able to see is that as the heart fills, there's an early collapse right there of the right ventricle during diastole. And that's because when you can barely even see the right atrium here. The lowest pressure chambers in a normal patient would be the right atrium, so that would be the first to collapse. And then the next lowest pressure chamber is the right ventricle in diastole. And that diastolic collapse here is what gives way to this strange movement of the free wall of the right ventricle. Here's another example of that. This time, instead of viewing from a subcostal view, being viewed from a left parasternal long axis view. So in the far field here, you can see the descending aorta. You know that any fluid-filled space in the near field compared to the descending aorta would be the pericardial space. So fluid in the pericardial space. Here you can see that there's a little bit of collapse of the left atrium. And then here you can see that same abnormal motion of the free wall of the right ventricle in the near field up here. This is an image from a transthoracic apical four-chamber view, again demonstrating this collapse to the right ventricle. And here you can also see a little bit more of the collapse of the right atrium as well, and also the left atrium here, with fluid being present on both sides of the heart. To further go on through the exam, if you look at the IVC, because the level of obstruction is the level of the pericardium, you might see underfilled chambers in the pericardial space. But if you scan to the IVC, you'll usually see a dilated plethoric IVC with minimal respiratory variation. And that's because the venous return is finding a source of obstruction as it tries to drain back into the heart. That finding of pulsus paradoxus is also something that has a sonographic correlate as well. In this view, what the team is doing here is putting pulse wave Doppler, and you can see on the screen that's designated here as pulse wave, right at the mitral leaflet tips to look at mitral inflow, and then comparing that to the respiratory cycle here. So right now you can see this is a time on the x-axis, Doppler velocities here on the y-axis, and you can see the velocities of mitral inflow change with this respiratory variation. That can also be used for diagnostic criteria to assess for tamponade as well. So if you have greater than 25% respiratory variation on the mitral inflow or greater than 40% variation on the tricuspid inflow, then that is a supportive finding for cardiac tamponade as well. And before we move on to the next topic, the other important thing that I'd really like to stress for the audience is that it's not really about the quantity of fluid, it's about the pressure in there. And because the pericardial space is poorly distensible, if it accumulates in a very short period of time, a very small amount of fluid can cause tamponade physiology. But if it's allowed to accumulate over a very slow and gradual amount of time, and eventually the pericardial space can dilate and accommodate for those increases in volumes without increasing the pressure to the same extent. So don't be fooled by the amount of volume, but we really have to look for the physiologic changes that are related to the increase in pressure in that space to be able to diagnose tamponade. Other types of injuries that can happen to the chest would include things like blunt cardiac injury. And if you suspect that a patient might be hypotensive as a result of blunt cardiac injury with myocardial dysfunction, you might be able to assess that in a couple of different ways. In terms of how we think about the heart and breaking it down into different segments, the American Heart Association divides the left ventricle into 17 segments, which you can see on this graphic here. At the basal and mid-papillary levels, it's subdivided to 6 segments: an anterior and inferior wall, and then the septal wall gets subdivided into infraseptal and anteroseptal. The lateral wall gets subdivided into infralateral and anterolateral. And as you move towards the apical level, those two levels aren't subdivided in the same way. You just have a septal wall and a lateral wall. The apical cap consists of is what the 17th segment is. In terms of scoring the motion, there's a couple of different ways that we do it, but this is probably what you'll see on the vast majority of echo reports. So in this segmental wall motion scoring, the number itself may be less useful to you than the classification and the characteristics that we use to describe them. So a normal functioning myocardium, because it's muscle, should increase in thickness greater than 50% and move with normal or increased velocities. If it's hypokinetic, that'll be less than 30% thickness, and you might see delayed velocity, especially when compared to the myocardium surrounding it. We describe it as akinetic if it increases in thickness less than 10% or is immobile, and dyskinetic if it is not even able to keep up with the increased pressures inside the left ventricular cavity and moves outward during systole. So in this case, you can see how different aspects of the myocardium don't really contract the same. This particular example is the case of ischemic cardiomyopathy with wall motion abnormality. But in cases of blunt cardiac injury where the heart might be dysfunctional, you may be able to observe something that looks very similar. The myocardium up here in the near field looks like it's thickening and moving very well. And further away from the probe, it does not look like it's thickening and contracting appropriately. Moving on to diagnostic injuries of the aorta. The aorta can be imaged from a couple of different viewpoints, and depending on where you suspect pathology is, you might have to look for it in a few different places. So if you're trying to image across the chest, then the takeoff of the aorta can be observed here in the left parasternal long axis. So when you place the probe there, typically between the third and fifth intercostal spaces with your orientation marker towards the right shoulder. This is the ideal view of what you would hopefully be able to image: the right ventricle and the near field, left ventricle and left atrium further out. And then you can see the aortic valve and the ascending aorta right in the middle part of the screen. If you need to image a little bit further away from there, you can move on to the suprasternal notch. That's a window right at the sternal notch. It might be difficult to obtain in some patients, especially if they have a cervical collar on. But if you orient the probe in the long axis of the aorta, you may be able to image the aortic arch from the takeoff, as well as some of the major branch vessels as they come off, and as well as the right pulmonary artery right here. As you image further down, you'd have to use the liver as an imaging window. So from here, as you move further down into a subxiphoid view, you'll be able to image the aorta in short axis. You'll be able to differentiate the aorta from the IVC because the aorta is next to the spine, whereas the IVC is encased in liver. As you're imaging, you'll also see that the aorta typically has a rounder profile and pulsatile waveform. The first branch off of the aorta that you see down here will be the celiac axis, which you can see depicted here. Has a seagull appearance or seagull wing appearance, where you see this branch coming off with what appears to be some seagull wings as it subdivides here. As you direct the probe further down, you might be able to image between the celiac artery to the superior mesenteric artery. Here you can see that up here encased in mesenteric fat. So there's the SMA and the splenic vein just right around that. Very rarely you might be able to image all the way down to the bifurcation of the aorta. One of the challenges of imaging this low is that once you scan past the liver as an imaging window, what you end up seeing is a little bit of obstruction from bowel gas in most instances, but every once in a while, you might be able to either apply a little bit of gentle pressure to help move some of that bowel out of the way, or just place the gas in it to be able to image all the way down to the iliac arteries. Here are examples of some aortic pathology that you might be able to see. Large aortic aneurysm with intramural thrombus. This might be a problem that might be a little bit more chronic than a typical trauma patient might have. But from these images, you may also be able to detect if there's any aortic dissections that might be visible from this view. Moving on to imaging the lung and diagnosing various types of lung injury, there are several that could potentially come up that are worth being able to understand. But before we really describe what the findings would be, it's important to know a few key features. There are many limitations to using lung ultrasound to diagnose various traumatic injuries. The first one being that air is a very poor conductor of ultrasound. That means that if you're trying to diagnose a traumatic injury, it's important that the pathology that you're looking for is in direct continuity with the ultrasound beam. If it's surrounded by well-aerated lung, you really won't be able to image it well because the air will interfere with the ability for the ultrasound to get to the zone of interest and then come back to the probe. That means that if you don't look in the correct spot, it might be very easy to miss what you're trying to find, even if it's present. When we think about the different imaging protocols that have been published on, It's worth knowing if you're trying to think about the sensitivities and specificities of these different imaging modalities, what type of protocol was used by the study authors. So here are some examples where they're using different scanning protocols to look at different zones of the lung. And you might see that some of them are very comprehensive and image multiple zones. Some of them are usually a little bit quicker. So the amount of time it takes to find this image can vary depending on the protocol, and the sensitivities and specificities can as well. The next thing to know is that if you don't know what you're looking at, it might be very easy to misinterpret the finding. And that's because a lot of what we're doing when we look at lung ultrasound is making an interpretation of the artifacts of lung ultrasound. And to go through some of those, I'll start with the first one up, A-lines. In terms of why A-lines come up, they happen because air-filled lung does not transmit ultrasound waves very well, and that leads to repetitive horizontal lines due to the repeated reflections of the pleura, because the pleura is a very strong echo reflector. So this is an example of what you might see when you have A-lines behind a source that seems to be well aerated here. Other times that you might see this, for those of you who perform regional anesthesia, you might see the same type of reverberation artifact with other strong echo reflectors like certain types of ultrasound needles. A-lines aren't in and of themselves diagnostic of too much, but what they mean is that you're insudating an airspace deep to a strong echo reflector. And that can happen for a number of different reasons. You could have normal healthy lung tissues. You could have a patient that has pneumothorax, or a patient with emphysematous lung changes, or a bleb that you're imaging over. So to be able to further differentiate between some of these causes, you have to move on to another step of the exam, which is to perform an assessment of the pleura. The reason for doing that is to separate pneumothorax as a potential cause for your finding from normal healthy lung with appropriate lung sliding. The technique for doing that is that you switch to a high frequency linear probe. And by ultrasound convention, that's typically oriented in the 12 o'clock position towards the head. And then you have to assess multiple lung fields where you expect to observe a pneumothorax. The way that we interpret that is that if you see pleural sliding, that means that there's appropriate approximation of the visceral and parietal pleura with appropriate sliding of the two. Absence of pleural sliding in an appropriate context may suggest pneumothorax, but is not inherently diagnostic of that. So other reasons that you might see absence of pleural sliding is a patient that has a bleb, if the patient is apneic at the time of the exam, if a patient is intubated and you've inadvertently performed bronchial intubation and you're imaging the non-ventilated lung, it may not be titling appropriately. If a patient has atelectasis, you may not see pleural sliding either. But you might see other forms of movement, such as cardiac oscillations, which is referred to as lung pulse. That suggests some problem other than pneumothorax, because there is motion of the visceral and parietal pleura against each other. It's just being imaged from a different reason other than normal tidal sliding. So when you're imaging the pleura, here's an example of something that you might see. These are rib shadows, which because rib is bone is a very poor ultrasound conductor, there's a lot of shadowing and dropout deep to that. Here in the near field, you can see some of the muscles of the chest wall, whether that's anterior or posterior. Between the ribs, you can see this very bright line that has a shimmering quality as it moves back and forth. That's the pleura. And that motion that you see here is the sliding of the visceral and parietal pleura against each other. Here's an example of what absent pleural sliding looks like. The image that you see deep to the strong echo reflector is just these chest wall muscles being reflected back by the ultrasound. So again, reverberation artifact, but instead of being from well aerated lung, it's all just coming from the pleura here. To be able to differentiate that, you can use M mode, which helps get you the best temporal resolution for any scan plane that you're looking for. If you have appropriate sliding of the visceral and parietal pleura, what you get is something that we refer to as sandy beach sign, where you can see the sand here and the far part of the image and some waves up here in the near field. If there's absence of pleural sliding, then we describe that as barcode sign because it looks a little bit like a barcode. You can see that here. This static line, the image isn't really changing much over time in the same way that you do here with this image of pleural sliding. This is an example of what lung pulse might look like. So as mentioned, pericardial oscillations might have an effect of motion on the pleura. So if you see these rhythmic movements that correlate to the heartbeat, then that suggests that the visceral and parietal pleura are well opposed, and that the movement that you're observing is due to some other reason. When you're looking at imaging for pneumothorax, it's important to be imaging in the correct plane, because if you have a supine patient, the air in the thoracic space will accumulate in the most apical position of the chest. So that'll be towards the sternum for a supine patient. That means that the further lateral you image, the more likely you are to find appropriately opposed lung tissue, and the closer you are to the sternum, the more likely you are to find that pneumothorax. Sometimes you can image the transition point between where the lung slides in and where it slides out. That is a finding referred to as lung point, and that is diagnostic for pneumothorax. So here in this image, what they're showing is with inspiration, they're imaging at a level where the visceral and parietal pleura do come into contact, and then on expiration, the lung is collapsed and out of the way, and it's missing there. So to see what that looks like, here it is. You can see at one point in the respiratory cycle, there's no pleural apposition, and then at some point it pops in, and then at a lower rib space, or sorry, at a higher rib space, more towards the sternum, you don't see that at all. So this finding, if you observe that, that is diagnostic for pneumothorax. And an example of how that resolves with presence of a chest tube, you can see that pleura coming right back in as the air in the pleural space gets evacuated. Being able to localize that lung point happens to correlate surprisingly well with the extent of pneumothorax. And that's been looked at in a couple of different studies. In this one, they used chest CT to assess the size of the pneumothorax and compared that to the sternum lung point distance, which here in the study they abbreviated as S-LP. And here that distance, the distance from the sternum to find lung point, happens to correlate reasonably well with pneumothorax volumes. And if you were wondering how it compares to CT to assess that, you can see that the sensitivity and specificity are 83 and 82% respectively. So certainly not perfect, but it performs reasonably well for a point of care test. Moving on to the next subject here, B-lines. B-lines are due to ring down artifact. And that's when a ring of bubbles with fluid trapped centrally causes fluid reverberations that leads to this artifact that displays a signal behind the true source of the echo. B-lines tell you that there's fluid in the lung parenchyma, and that might be to any number of reasons, and you'd have to suspect that based on the patient's clinical context. It could be pulmonary edema, inflammation or infection, consolidation, or contusion, which might happen a little bit more frequently in a patient that has an injury to their chest and had received a lot of fluid resuscitation to help get them through that. To perform an exam for B-lines, there might be a couple of different things that you'd want to use, like a lower frequency curvilinear probe or a typical transthoracic phase array probe oriented in the 12 o'clock position. Set the depth typically to 13 to 16 centimeters, and then count the number of B-lines you see between the rib space. If you observe greater than 3 B-lines, that's considered pathologic, and the severity happens to correlate with the number of B-lines. So a patient might have normal lung tissue if you have less than 3 B-lines, mild pulmonary edema or edema in that lung parenchyma if it's at least 3 and they're intermittently present, moderate if they're several or they're partially discrete. It's severe if they're completely coalesced and persistently persistent. So here you can see a couple of different examples. These B-lines here, there's only a few between the rib space. Sometimes they're there, sometimes they go. Here you can see these are persistent and they're always there. You can actually see that there's multiple between each rib space. Other things that you might find if you're imaging the lung would be an effusion. So if you suspect that a patient might have a pleural effusion or hemothorax or any other cause of fluid in the pericardial space, that might also be observable here. One of the things that people frequently refer to here is the spine sign. Again, because the lung is a very poor conductor of ultrasound, if it's well aerated, you shouldn't be able to image all the way back to the spine. But if you can see that, that suggests that there's fluid or some other process that's going on that allows the ultrasound to pass all the way through the lung or the pleural space into the spine to be able to allow you to get this image of the ultrasound dropout of the spine. This is an image here. This is the diaphragm. This would either be the liver or the spleen, depending on which side you're looking at, and the kidney below that. The pleural space is the space here above the diaphragm, and this hypoechoic field here that you see suggests that there's some fluid in there. Here's another example. Again, in the far field, you can see that spine sign. This may not be as clear as the previous image, but you can clearly see something that looks like it might be the spine with ultrasound dropout deep to that. This curved space where the diaphragm is, either the liver or the spleen up here on the right side of the screen. On the left side of the screen, you can see a simple anechoic fluid pocket around some consolidated lung. When the lung gets consolidated, it takes on an echo texture very similar to either the spleen or the liver, but these bright spots are little bits of air that are still within the lung. This is a little bit more of a difficult situation to deal with. Here you have an effusion that's loculated. So the difficulty here is that a chest tube placed into any pocket space may not completely drain this effusion. And it might suggest that the cause for the effusion is something a little bit more worrisome than just a little bit of edema or simple fluid that's collected there. In putting it all together, there's a couple of different ways in which we can assess patients that have acute lung injuries, and they've got summarized very nicely as the blue protocol, where first thing that we might look at is whether lung sliding is present or absent. If it is present and you see an A profile, then you might be going down a couple of different set on the criteria. If you see a B profile, that excludes the possibility of pneumothorax. So there what you're seeing is probably pulmonary edema. If the lung sliding is absent and you still see that fluid in the lung because of B lines, probably because of a pneumonia. If you see A lines plus lung point, that's definitely pneumothorax. If you see A lines but no lung point, you have to double check and make sure that it's not just missed. So further studies may be necessary. And just to wrap it up, the other thing that you can use that ultrasound for is if your patient has a traumatic brain injury, the normal way that we diagnose elevated ICP as a simple point of care test non-invasively would typically be to look for papilledema. Now, I personally have never been successful at doing this. I'd like to believe that you guys are much better at this than I would be, but this can also be easily obtained using ultrasound. If you apply a tegaderm over the eyelid, you can put some jelly over that tegaderm and then take an ultrasound image of the eye. The technique is relatively simple. What you want to do is to find this optic nerve sheath, which is the hypoechoic structure that connects to the globe here. You want to put the calipers to measure 0.3 centimeters or 3 millimeters past where the globe is, and then measure the diameter of the optic sheath, outer diameter to outer diameter, inner wall to inner wall, 0.3 centimeters across. If the width of the optic nerve sheath is greater than 0.5 centimeters, that is suggestive of optic nerve sheath dilation, which is associated with increased intracranial pressure. And it's actually finding that's relatively sensitive and specific, and performs pretty well here for the quality of the test. However, if a patient has serious facial trauma, you might find other pathology that you weren't really looking for. So if you observe either vitreous hemorrhage or retinal detachment, my recommendation there would be to consult an ophthalmologist. With that, I wanted to open it up for any questions.
Thank you, Dinesh, for that once again awesome presentation. You never fail to achieve the standards. Can I ask that we keep your questions into the Q&A session, so that we can all benefit from a joint session on questions. So Dr. Dalton has graciously agreed to step up, and we've had a little reshuffle of the deck. So she's going to present to us next, whilst we give Amos more time to get connected. So Dr. Dalton is an associate professor in anesthesiology and critical care at the University of Chicago. She's also the associate chair for education. So Ali, over to you. Thank you.
No, thank you so much. Let me go ahead and get my slides up here in a reasonable way. Are you able to see just my slides?
Yes.
Excellent. Well, first of all, thank you so much for the kind introduction and for the privilege to be able to come and speak today about trauma in the traumatologist. We'll also be discussing, obviously, strategies to help mitigate secondary trauma and compassion fatigue. I do have a disclosure. I've actually received funding from the Bucksbaum Institute here at the University of Chicago regarding some of the work that I do in peer support. At the conclusion of today's presentation, one should be able to define secondary trauma and compassion fatigue. I want us all to be able to identify the emotional, mental, psychologic, and physical effects of secondary trauma on the healthcare provider, and to be able to describe potential mitigation strategies to combat secondary trauma and compassion fatigue, as well as burnout. This is Mercy Hospital and Medical Center in Chicago. Unfortunately, on November 19th, 2018, a gunman opened fire outside of and then inside of their emergency department. Victims from the attack were brought to surrounding level 1 trauma center. And unfortunately, 3 of the victims, Samuel Jimenez, a Chicago police officer, Dr. Tamara O'Neill, an emergency medicine physician, and Dana Less, a pharmacy resident, died as a result of their injuries. While we care for patients who have experienced trauma as a routine part of our daily work, some of these cases can leave a lasting impact. One way that our patients have inevitably left an impression on us is the emotional impact that their traumatic experiences have on those around them. Secondary trauma is actually a form of stress that results from helping or wanting to help a traumatized or a suffering person. Secondary trauma is associated with other effects of caring for traumatized individuals. While secondary trauma can occur from one distinct interaction with a patient, vicarious trauma relates to an ongoing process of change over the course of time that ends up resulting from witnessing, or as a result of witnessing, other people's pain and suffering. Vicarious trauma is associated with negative changes in a clinician's view of themselves, of others, or even of the world as a result of repeated empathetic engagement with the patient's traumatic-related thoughts, memories, or emotions. With repeated exposure to secondary trauma, clinicians may start to experience compassion fatigue, which has psychologic, cognitive, and interpersonal effects, leading to anxiety, isolation, avoidance, mistrust of others, cynicism, maladapting coping strategies, and even compulsive or addictive behaviors, including substance abuse. It can be characterized by emotional and physical exhaustion, leading to diminished abilities to empathize or to feel compassion for others, and can manifest as burnout. Burnout specifically relates to a constellation of emotional exhaustion, depersonalization, and reduced personal accomplishment. Not every trauma patient's experience, though, will elicit a secondary traumatic stress response in a provider. Multiple risk factors exist that can predispose clinicians to higher likelihood of developing secondary trauma related to any specific event. The interplay between these risk factors are complex and can end up being variable. Secondary traumatic stress has multiple symptoms, including those within biologic, behavioral, or psychologic domains. Clinicians experiencing secondary trauma may have sleep or appetite disturbances, new or worsening fatigue, may be more likely to become irritable. They may suffer from headaches, GI upset, cardiac symptoms, and issues with sexual desire or performance. In addition, those who suffer from secondary trauma may end up isolating themselves from others and may have issues with poor work performance or trouble meeting personal commitments. Psychologically, clinicians may experience sadness and grief. They may ruminate over events. They may struggle with concentration or memory, and may end up having increased sensitivity to violence in the future. Unchecked, secondary trauma may be associated with anxiety, PTSD, substance abuse, depression, and even thoughts of self-harm. Given the frequency of us witnessing patient suffering as part of our routine daily work, how common is secondary stress in traumatologists? In a study by Anne-Marie Warren, 2/3 of surgeons actually self-reported at least some degree of secondary stress, with a little over 10% of these surgeons noting high degrees or severe secondary stress symptoms. In addition, 1 in 5 surgeons actually met the criteria for PTSD in all 3 domains: intrusion, avoidance, and arousal symptoms. In addition to high levels of STS and PTSD, those physicians who provide care to trauma patients may have increased levels of burnout. Medscape recently released the results from its physician burnout and depression survey, over which 13,000 US physicians participated. Physicians were recruited between June and September of 2021 in order to fill out these surveys. Over the course of the last year, the average physician burnout rates have actually increased from 42% to 47%. Staggeringly, EM physicians' rate jumped from 43% last year to 60% over the course of one single year. Other physicians who commonly care for trauma patients also have high rates of burnout compared to many other specialties. Over half of intensivists, nearly half of anesthesiologists and surgeons also report burnout. The Medscape rates are also validated in other studies. This study by Jackson et al. Found a burnout rate of 30% in trauma surgeons in the year 2019 and a PTS rate of 17%. In a survey study by Brown and colleagues, 61% of trauma surgeons self-reported burnout, and another 57% reported dissatisfaction with their work-life balance. Balk et al. Found a burnout rate of 51% amongst trauma surgeons, which is the highest amount of burnout among all of the surgical subspecialties that they evaluated. Alfonso et al. Found that in a survey of nearly 4,000 anesthesiologists that 59% are at high risk for burnout, and about 14% actually meet all the criteria for burnout syndrome. There's also been recent data in the journals for emergency medicine, noting burnout risk anywhere between 40 and 90%. It's not just our physician force that actually is experiencing burnout. In fact, the nursing colleagues, when surveyed, actually reported higher rates of burnout than even our emergency medicine physicians. And we also see that police officers experience similar rates to our physician colleagues as well. So what really contributes to the emotional exhaustion, depersonalization, and low personal accomplishment associated with our work? 60% of respondents note that charting, paperwork, and other bureaucratic tasks contribute significantly to burnout. About 40% actually note a lack of respect from administration, colleagues, or other staff. And about 30% physicians note that issues with work hours, salary, or issues with the computerization of practice contribute to their burnout symptoms. Similar results have been demonstrated by Dr. Christine Stemmen and her group, who evaluated burnout in emergency medicine. They noted that secondary stress combined with financial and clinical pressures, as well as fatigue, can lead to burnout. Risk factors common to burnout, regardless of specialty, include things like fatigue, excess workload, long hours, excess administrative stress, lack of a support system, both inside, outside work, and struggles with work-life balance. While there are common risks for burnouts that each medical specialty experience, also each individual medical specialty may have other specialty-associated risks. For example, anesthesiologists may struggle more with lack of personal connections with patients and their families, or lack of continuity of care. These could potentially lead to decreased feelings of personal accomplishment, increasing their risk for burnout. Elkbooley and colleagues actually sent a survey to about 1,700 current members of the Eastern Association of Surgery for Trauma, or EAST. While physician gender has shown varying effects of burnout in other previous studies, the strongest predictor of burnout in this study was actually female gender, with an odds ratio of nearly 20% the risk, even after adjusting for things like hours worked, race, gender, age, practice setting, years of clinical practice. Other predictors of burnout included hours worked per week, including those who work between 70 to 79 hours a week, had an increased risk of burnout of about 49 times norm. The study also assessed suicide risk. Trauma surgeons between the ages of 30 to 34 actually were at the highest risk for having thoughts of self-harm and had an alarming risk rate of about 36%. The severity of burnout symptoms can vary in individual physicians. Over half of those who reported burnout in the Medscape survey rated their symptoms as severe and having a severe impact on their life. When additionally looking at this, they actually found that 2/3 of physicians noted that burnout had a negative effect on the relationships in their lives as well. Other effects of burnout include fatigue, headaches, cognitive dysfunction, and changes in sleep and appetite. Those physicians with burnout may become irritated more easily and may find it harder to empathize with patients, colleagues, family, or friends. Many physicians with burnouts have less work satisfaction and may manifest issues with job performance or even absenteeism. Interestingly, burnout has also been associated with increased risks of cardiovascular complications and increased risks of diabetes, obesity, and substance use. Burnout can also be contagious within a group or an institution. In addition to substance abuse, burnout has been associated with physician attrition, depression, and even physician suicide. Physician burnout has an effect on more than just the individual provider. Al Ghanem and his group performed a meta-analysis to evaluate patient safety and the effects from burnout. The publications included in this meta-analysis utilize self-reported data regarding medical errors. As you can observe in most of the studies here, you see that surgeons with burnout actually reported higher risks of medical errors. When the study group evaluated specific burnout domains leading to errors, they more often found that the physicians who had high emotional exhaustion scores had higher rates of increased medical error. They also found that high depersonalization scores did not have an effect on this. With such high rates of physician burnout and such potentially devastating effects, it's increasingly important to help identify clinicians at risk and to provide resources to help mitigate those risk factors. Given the diversity of experiences, triggers, and effects on secondary trauma and burnout, there can't be a one-size-fits-all model. Therefore, ideal wellness programs consist of a variety of varying personal resilience and organizational programs to assist providers in combating burnout and secondary traumatic stress disorders. Mitigation strategies can fall into 1 to 2 categories: individual or organization or institutional strategies. Given the interplay between burnout and fatigue and mental health, it's important to try to prioritize self-care as a means to decreasing burnout. While often difficult to squeeze in that after work workout at one's gym or to actually make it to your own primary care appointments, these interventions are actually very important and have been shown to decrease risk of burnout. Social support, again, both inside the workplace and also outside the workplace, is increasingly important. This really helps to minimize loneliness and isolation that people might feel. Organizations can also work to create a culture of well-being, as well as offering education regarding burnout, secondary traumatic stress, and mental health, in addition to trying to minimize administrative and bureaucratic work. Organizations must also work with their clinicians to develop strategies to optimize work-life balance and can develop peer support to combat burnout and PTSD related to secondary trauma. When asked how physicians cope with burnout, nearly half reported exercising being helpful. Others sought additional self-care methods, including sleep, healthy eating, and listening to music. However, many physicians also reported somewhat damaging habits to help combat burnout, including isolating themselves, unhealthy eating, and potentially alcohol and drug use. Resiliency has become, over the course of time here, a somewhat provocative topic. I actually seek to offer a different definition of resilience than maybe what you think of when you initially hear this word. I see resilience as the process of adapting to stress over the course of time. While it was really once thought to be an innate personal characteristic, personal resilience is really the result of the intersection between protective factors and threats. Resilience is also strongly associated with self-reflection, competency, confidence in one's work and one's abilities, optimism, and social support. Brown et al. Actually surveyed members of the American Association for the Surgery of Trauma members Of note, only about 43% of those surveyed actually noted that they were satisfied with their personal work-life balance. Having more time to be awake at home, being able to leave work early for personal time, having and participating in hobbies were really the things most associated with higher satisfaction and work-life balance. Interestingly, coming in late because of personal requirements or personal needs actually had little significant effect. Surgeons who exercised, ate a healthy diet, and got at least 7 hours of sleep per night had higher rates of work-life satisfaction. While there's no real difference in the number of vacation weeks allotted to the providers that were surveyed here, those who actually used less of their granted vacation time had much lower satisfaction scores. And finally, those who feel emotionally supported and those who are satisfied with their personal lives outside of work were actually more satisfied with their work-life balance as well. Aside from the aspects of self-care, there are additional ways in which we can personally affect our well-being and decrease burnout and compassion fatigue. Remember again that no single resilience technique will be meaningful or beneficial to every single provider. Mindfulness is really based on a Buddhist practice of meditation. It focuses on 4 main tenets: attention regulation, body awareness, emotion regulation, and changing one's perception of self. Mindfulness focuses on being fully present and aware of where we are and what we're doing in the moment. It works to minimize reactivity and stress. Mindfulness activities can be as simple as taking slow, deep breaths. Another mindfulness activity can have you intentionally focusing on the muscles in your body and intentionally relaxing muscles from your facial muscles to your shoulders and so on and so forth through the rest of your body. Another mindfulness activity is the act of journaling and focusing on one single stream of thought at a given point in time. Other techniques that have been effective against burnout include cultivating gratitude, employing self-compassion, practicing empathy. We should also seek to cultivate relationships, whether this be by informal social gatherings outside of work, formal social meetings within the workplace, or other gatherings to enhance and maintain interpersonal connection, and again, to help prevent against isolation, burnout, and depression. In addition to personal resiliency, many physicians have actually already attempted to alter their specific work environment in order to decrease risks of burnout. Some have decreased hours or changed work settings. If this is an impractical solution for you, you could seek to make changes to your clinic, emergency room, ICU, or OR workflows to attempt to ease some of the bureaucratic workload. In an interesting article entitled "Physician Disrupt Thyself," Dr. Nathan Fisher actually analyzed how to build both personal and institutional resiliency in the medical system, which can allow for professional growth, potentially improving personal accomplishment scores and reducing burnout. In addition to building stronger relationships, he and his colleagues introduced ways for institutions to change the existing healthcare model to support physician well-being. The authors suggest that rather than working to achieve work-life balance, physicians and systems should move towards work-life integration, which allows for personal resiliency to relate to our ability and our capacities to maintain our humanistic values, our life purpose, and our goal-focused care in order to change the circumstances in which we work. This new perspective actually realizes that ultimately medicine actually permeates all the aspects of our lives and our personhood, and that obviously we aren't leaving our work behind us as a 9-to-5 job as we walk out of the doors of a hospital in the evening. They also found that too much standardization and protocolization of the healthcare practice can devalue our humanity and can decrease our feelings of personal accomplishment. To that end, building healthcare systems that can provide some degree of diversity can actually improve well-being and decrease burnout in providers. The authors also encourage physicians to strive to regain leadership roles in healthcare systems in order to realign the patient, provider, and institutional goals. While large changes in the overall healthcare system will take time, there are ways that we can actually make changes currently in our current systems. Bell and colleagues sought to identify other possible institution or organizational actions that we can use to decrease and prevent secondary trauma. They noted that it's important that organizations have a collective understanding that we will all inevitably be affected by what we do in our work, especially the work that we do with traumatized patients. What we should do to avoid those effects leading to clinicians feeling ineffective, unskilled, and powerless. And this is really due to the continuing nature of us caring for these patients with trauma. Organizations can first encourage clinicians to participate in activities that provide self-care, such as taking all of your allotted vacation time, limiting required overtime, allowing providers to take time for illness and FMLA, and encouraging time away from work for continuing education purposes. Another important aspect of avoiding especially vicarious trauma is to provide avenues for hope, including opportunities for outreach, education, and advocacy for our patients. Organizations must provide a safe working environment. They should also provide education about secondary and vicarious trauma in order to help providers identify the signs and symptoms of these traumatic conditions in both themselves and in their colleagues. And finally, organizations can work to try to provide effective group or peer support systems. In addition to the provisions recommended by Bell, physicians also cite that time, money, and autonomy are additional ways to help decrease burnout. Lighter patient loads, more manageable work schedules, and hiring additional support staff may help clinicians to find better work-life balance and find the time for self-care that's so highly recommended. Other physicians worry about this financial stress related to work and note that burnout would improve with increased compensation. If one's workplace were to develop programs or tools to enhance physician and institutional resilience, how helpful would these interventions actually be? As it stands, about 40% of physicians are aware of programs to assist them with stress or burnout within their workplace. But up to 60% of physicians surveyed would actually be willing to participate in services if they were offered. This provides a very large potential market for services, as there's an obvious physician need as well as significant interest. One potential obstacle for those 40% of physicians who don't want to seek additional support can be related to the culture within healthcare that currently exists. Even for those who self-identify as having burnout or depression, many often don't seek treatment. I think that this is really the result of one of two processes. The first is that the physician feels that they can deal with the symptoms without professional assistance. Physicians truly are well known for having very high degrees of resiliency, and that with appropriate coping strategies that we've all developed over the course of our lifetime and our careers, we really can handle significant adversity, whether it's in work or at home. So I'm actually perhaps more concerned about the second category, which is really mistrust of the system. Many physicians actually note that the stigma associated with this asking for and receiving assistance with the symptoms related to burnout or depression will prevent them from ultimately seeking help. Unfortunately, there's still many state medical boards out there that ask about treatment for medical health conditions in the state licensing process. We're also afraid that our colleagues may judge our abilities to be resilient or to provide appropriate clinical care if we have symptoms and that we're seeking treatment for conditions. So one really can't emphasize enough that changing the culture of the healthcare system really needs to be a priority. Hugh et al. Actually conducted a similar study specifically for emergency medicine physicians, surgeons, and anesthesiologists. When asked about triggers for seeking help, these physician groups actually noted involvement in adverse patient events, medical errors, legal action, substance abuse issues, illness, and interpersonal conflicts as the primary drivers to seek assistance. Interestingly, though, less than 10% of respondents found that personal burnout would actually prompt them to definitively reach out for care. When analyzing barriers to seeking support, Hugh actually found that it mirrored the previous results, with stigma and lack of confidentiality being the major barriers to seeking support. In addition, many physicians cited lack of time as a reason for not being able to seek care. Over the last decade, more organizations are working to develop programs to assist with physician well-being. But just as every provider will have different reactions to various trauma experiences, not every provider will benefit from the same type of interventions. Therefore, comprehensive wellness programs really need to be dynamic and multidisciplined in order to reach a wide, diverse workforce. This is actually very nicely shown here in the study by Schanefeld. Different participants within this medical organization have different stressors, and these wellness programs really should seek to provide for each individual's needs. Schanefeld actually noted that while all of these members, our physicians, our nurses, our APPs, and our non-clinical allied health providers actually suffered from dysfunction within care teams, issues with leadership, physicians may require additional assistance with things like liability, responsibility, and academic promotion, whereas nurses may require more support for mistreatment by other team members and for moral distress. In addition to dynamic and multidisciplinary programs, clinician education should really be of pivotal importance. Organizations should have programs to decrease work-related stress, including inefficiencies within the system, like electronic health records. Institutions should provide sufficient time and financial support to our providers. And in order to decrease isolation, especially in regards to secondary trauma, group or peer support can be beneficial. Now, many of us are familiar with the concept of trauma-informed care and its utility for our patients. Trauma-informed care seeks to reduce potentially traumatic aspects of patient treatment in an effort to avoid re-traumatization when they present for assistance. Trauma-informed care may not only be beneficial for patients, though, and may be beneficial for providers as well. Clinicians who provide this trauma-informed care may actually see reduction in burnout, improvements in equity, and may have additional beneficial effects down the line. As traumatologists, we can assume that most, if not all of us, have been exposed to traumatic situations and may have been the victim of secondary trauma ourselves. I actually wonder if utilizing factors of trauma-informed care for ourselves and for our colleagues may provide benefit. As another means to care for colleagues who experience secondary trauma, peer support can be employed. Peer support is actually the provision of emotional or psychological care by those with common life experiences. In secondary trauma, the goal of peer support is really to provide timely, confidential, psychologic, first aid, and emotional support to a colleague after an adverse event. In the above model here, designed by Susan Scott, there are 3 tiers of peer support that are identified. Tier 1 support is likely what you're already doing. These are colleagues who reach out to someone who's had an adverse event and end up having those hallway conversations. This also can include, reassurance from your colleagues or just talking through important or monumental cases. Tier 3 support there at the top of the pyramid is really that support that's offered by professionals. These professionals have essentially extensive training in counseling, and the people who provide this type of support really are people like psychologists, social workers, or chaplains. What I'm going to spend a little bit more time here talking about is really this Tier 2 support. Tier 2 support involves crisis management and interventions for crisis management, peer support mentoring, and team debriefs that can be provided by team members with some additional training. This training oftentimes includes things like second victim symptomatology, peer support fundamentals, and how to perform a one-on-one intervention. Peer support may be delivered to individuals or in a group setting. One example of a peer support program was just featured in the Wall Street Journal in this article from January of this year. Mark Schimmelfinnig, who was a former combat veteran, and Kim Sangster, who's a bereavement support and education coordinator, developed a program actually at a local hospital here in town called Growing Forward. This program was designed as a model that used some military programs which have been used for soldiers who have experienced grief and PTSD in the past. This specific program actually was designed for nurses who have been working in a hard-hit COVID-19 unit where burnout risk has been exceedingly high. They actually performed sessions that consisted of 6 30-minute sessions where they would have group essentially support meetings where they discuss moral injury, self-compassion, and other topics. There have been many other examples of peer support presented in the formal literature. Ben Pelt described the creation of a peer support group at Brigham and Women's University and their hospital following a patient encounter in which unfortunately a patient required an emergent sternotomy and cardiopulmonary bypass following what seemingly was a routine administration of bupivacaine for a straightforward popliteal fossa nerve block for a total ankle replacement. Scott's article narrates the process by which their group actually collected data and then created a data-driven initiative for peer support at the University of Missouri Healthcare. The RISE support group is a group that was created at Johns Hopkins and was developed as a collaborative effort with leaders in patient safety, risk management, and clinical departments to help combat secondary trauma. There are other kind of national and international organizations that you can reach out to help develop programs within your own personal institution. Schwartz rounds are actually facilitated multidisciplinary support groups where the care of a challenging patient is discussed with specific focus on social and emotional and psychological perspectives while emphasizing the compassionate care. The Schwartz Center was actually developed by Ken Schwartz, a gentleman who unfortunately experienced a 10-month fight against advanced lung cancer before ultimately dying of this disease. He really developed the center to highlight and to encourage the compassionate care that he received when he was a patient within the healthcare system. Schwartz rounds have been found to decrease caregiver stress, as well as leading to better engagement and decreases in burnout, as well as enhancing teamwork within the medical teams. Another example of a national or international group are Ballant groups. These offer physicians time and space to be able to discuss patient encounters with colleagues. These groups are actually designed based upon the teachings of Michael and Enid Ballant, who are psychoanalysts in the 1950s. They actually went on to discuss patient and physician relationships and really started the idea of this patient-physician relationship that now permeates medical culture currently. The goal of the modern Ballant groups is really for physicians to be able to debrief the effects of difficult patient encounters, especially adverse outcomes, in order to really nurture a therapeutic relationship between patients and clinicians. Traditionally, these groups are facilitated by a psychiatrist, but can be facilitated by other people who have training within the realm of peer support. Participation in Ballant groups have been associated with decrease in burnout and in compassion fatigue. And finally, peer support has been implemented and utilized in other forms of moral distress, including during the most recent COVID-19 pandemic. The Battle Buddies program that's spoken about in this article by Albert was actually formulated based upon a model that's been used by the US Army in the past. In response to the lack of a trauma center on the south side of Chicago, the University of Chicago Medicine actually became a level 1 trauma center in May of 2018 for the first time in nearly 3 decades. Over the course of the first few months, we actually realized the emotional and mental effect that seeing all of these patients coming into our operating rooms, coming into our ED, had on the members of our anesthesia department. And at that time, we started to research potential options to mitigate the secondary trauma that we were seeing in the members of our department. We actually decided to work with a local psychologist who has expertise in peer support for both healthcare and law enforcement professionals. And he assisted us in training initially 3 faculty members, 3 residents, and 3 CRNAs to deliver peer support. The anesthesia peer support program was launched officially in September of 2019, over a year in the making. It took a full month before we actually had our first activation of our system. But since that time, we've grown significantly and are now a team that involves 17 faculty members, fellows, residents, CRNAs, and anesthesia techs. The goal of our program is really to be able to support those who have experienced traumatic events in the operating room and may be at risk for secondary and vicarious trauma. We also provide resources to those in our department who may be struggling with other sorts of difficult personal issues or even mental health struggles. In order to maximize prevention, we have two separate ways by which our peer support system is activated. First, any member of the department can reach out to us to speak to themselves or someone else who's experienced an adverse event. Secondly, we actually will proactively reach out to those who have had incidents, especially things like perioperative mortalities, cardiac arrests, significant airway management issues, medical errors, or other concerning perioperative events. Since our system launched, or since we had our first activation, I should say, in October of 2019, we've had a total of 240 activations for 111 separate events. Roughly 50% of our activations are related to perioperative mortality. An additional 20% involve perioperative cardiac arrest. 10% are associated with difficult airway management. And 7% of our activations are for other sorts of perioperative morbidities. The final 12% that's presented here are actually related to other issues that we've activated the system for, things like anxiety-related issues, depression, and even suicidal ideation. While we really started this group to combat the effects of secondary trauma from becoming a new level 1 trauma center, we've noticed that only a small percentage, or about a third of our cases that come through the anesthesia peer support are related to our level 1 trauma patients and our level 1 trauma cases. Over 50% of our activations have been in our trainees, who may be at a unique position early on in their careers, as this may be one of the very first encounters they've had with perioperative adverse events. We seek to really set a precedent on how to manage secondary trauma that hopefully will set a pattern for them as their career progresses going forward. After our first year having our peer support system active, we actually sought to determine how helpful this intervention had been for those who had an activation and had a peer support intervention. Of the approximately 90 interventions that we had at that time, we received about 42 responses. 76% were favorable. So in conclusion, I think it's important to really note that observing or participating in the care of a trauma patient can lead to secondary trauma in the provider. Secondary stress can really lead to short-term and long-term effects. Secondary trauma can also be associated with other kind of issues related to vicarious trauma. Those same providers can suffer with compassion fatigue, burnout, anxiety, depression, PTSD, substance abuse, and self-harm. There are ways that we can do, or things that we can do, to mitigate secondary trauma and to prevent progression to these conditions. And mitigation includes things like personal resilience development, institutional wellness programs, with specific attention to work-life balance, education, awareness and development of peer support to prevent a social isolation. The final and perhaps the most important point that I want to make is that we all need to start working and continue to work on developing a culture within every section, department, division, and institution in which it's okay to admit that one needs help, and to have situations and to have systems in place to be able to provide resources for those who do need assistance. And with that, I'll go ahead and stop sharing, and thank you so much for the opportunity to be able to speak today.
Ali, thank you very much. As usual, awesome. Please hang around for the Q&A session later on this morning. That brings us on to another reshuffle. Timothy Plackett is going to speak next. So welcome, Tim. Timothy is a lieutenant colonel in the US Army, and he's also a clinical associate at the University of Chicago in the Trauma and Acute Care Surgery Division. And he's going to talk to us about combat resuscitation and critical care on the future battlefield. Tim, over to you, sir.
Morning. Let me see if I can get figure out how to get my screen shared appropriately. And is that coming up?
Just click it into presentation.
We good there?
That's great.
Fantastic. Well, good morning, everyone. My talker is going to be on my own views. So while I do work for the Army and do wear a few hats with them, these are my own opinions, not necessarily the official policy or position of the Army or the Department of Defense. And just as a warning, I will be talking about several off-label use of various medications and devices, and we'll talk about that as we go through this. So the issue that we're kind of facing with the next battlefield is that after 20 years of counterinsurgency operations, we really think we've figured out, a good way of doing this. And if you look at the Russ Coatwall paper from 2016, while it focused on the effect of a golden hour policy, what you see is that from 2001 to 2016, there was a steady improvement in the case fatality rate. And what we want to make sure is that as we talk about the future battlefield and what's coming next or may come next, that we continue to sustain these improvements and avoid this so-called Walker dip, where there's a initial worsening of outcomes compared to where we last left off. So when we think about what could be next, the thing that we talk about the most right now in the military is large-scale combat operations. And we worry that this will be against a peer or a near peer, and that's going to occur in a multi-domain environment. So think about World War II, but add the complexity of information warfare, cyber warfare, and somebody shutting down all your communications, or worse yet, being able to send back misinformation through your lines and through deep fakes. You have no idea that it's a fake. And so this is the problem that we worry about the most. And so I'm going to give you a hypothetical scenario. I'm going to tell you these numbers I created several years ago as we started wrestling with the problem of what is the medical support going to look like for large-scale combat operations. But you're going to look at some of these numbers and they may sound eerily accurate for numbers we've seen over the last month or so. So if we assume that initially we're going to have 2,000 troops committed to whatever the next fight is, and that half of these troops are going to be involved in the initial operations on day one, our casualty estimates are that about 1.5 to 2.5% of all the individuals in the fight are going to get hurt each day. We know of those that are a casualty, about 10% are going to need immediate surgery. So these are the life-saving surgeries. This isn't even talking about some of those orthopedic things or other trauma that can wait several hours or wait a couple days. And so just running those numbers, through, that means on day one, we're going to have somewhere in the ballpark of 1,500 to 2,500 casualties. We're going to have 150 to 250 immediate surgeries that have to be done that day in order to save the life. And if you happen to have had CNN in the background in the last couple hours, these numbers are almost mirroring what President Zelensky is now saying that Ukraine has had over the last 17 days. So I think these estimates are fairly accurate. And it's a rather daunting task to know how much medical support we're going to have forward on day one, and to think that there's 250 patients that need an immediate surgery. The amount of resources that that's going to require, the amount of teams that we would need to bring forward, we really aren't able to do what we've been doing for the last 20 years with that many patients on day one. And remember, that's day one, which means the next day there's another 150 to 250 patients coming in. And because this is a near peer, because this is multi-domain, this means we may not be able to evacuate the patients. We may not be able to move them back from one level of care to the next. So those far forward surgical teams, those far forward resuscitation teams are going to have to hold on to patients a lot longer than doctrinally and traditionally we've had to do. So I think we're going to see a giant change overall in what the medical resource needs to look like or how it needs to behave. So as a result of that, I want to give you what is a flight of ideas of things that are coming down the pike to help with resuscitation, and then things to think about how we could bring forward to improve the critical care, to improve the overall outcomes that we're getting for the patients. So I'm going to start by talking about some resuscitation strategies, and everything I'm going to talk about is currently not US FDA approved, but it is all stuff that at one level or another is either at a phase 3 trial that is ongoing or is currently just awaiting approval from the FDA. So the first thing is freeze-dried plasma. And freeze-dried plasma is not new. this was used during World War II, and concerns about the blood supply and the risk of infection with the product is what led it to kind of get put on the back burner. More recently, the French have taken an active role in this, and they've developed the leukocyte depleted freeze-dried plasma, the FLYP. This is FDA approved under an emergency use authorization. It's only for DoD personnel, and it's only for combat injuries with hemorrhage or coagulopathy when plasma is either not available or not practical. The other product out there, and I think when you look at the literature, maybe a little bit more commonly used worldwide, is the German version, which is the lyophilized plasma or the Lyoplas. This is currently not approved by the US FDA. The benefit of freeze-dried plasma is that this is stored at room temperature and it's good for about 2 years. You reconstitute it with some saline in a matter of minutes and you're ready to go. What you avoid, especially for the military, is the need to have a -18 freezer for freeze-dried plasma. You avoid the 30 to 40 minutes it takes to thaw the product. And for those of you that have combat experience or have tried doing this in the field, you know that thawing plasma, thawing your FFP, probably 1 in 4 bags is going to break. So the fact that I have something that's not going to break every time kind of ups the game here. It allows me to give plasma at a much earlier phase. So what do we know about the freeze-dried plasma that's currently available? Well, there are several retrospective studies on its pre-hospital use, and that is what most of the data out there on it right now is focusing on, is pre-hospital use. They are all from either Europe or Israel. And what they've shown is that, number one, there's no adverse effects from freeze-dried plasma. So the infection risk is essentially zero. There's always going to be a theoretical risk anytime we use a blood product, a human blood product, but there's been no complications and there's been no transmission of any infections from it reported. There is no mortality benefit compared to FFP. However, no one expected there to be a mortality benefit. Really, we're seeing freeze-dried plasma as a replacement for FFP in certain environments. What it does do, although it's somewhat inconsistent in the studies, is it may decrease the use or the total number of RBCs that need to get transfused. And it may cause a slight improvement in coagulopathy. When you look at some meta-analyses that are out there, patients tend to have a higher fibrinogen level, higher factor 2, higher factor 5, lower INR when you look at that about an hour after the patient has arrived at the hospital. Somewhat intuitive, if I'm giving this before you get to the hospital and FFP is not being given pre-hospital, that yes, if I put those clotting factors in there, maybe you'll bleed a little less, and then I won't need to transfuse you as much, and you'll just look a little better an hour after you've arrived. So for the military, our question is this going to be stable? Is it going to last? And the best study out there right now is this Israeli study. And what they did is they had freshly supplied freeze-dried plasma, and they were using the German variant. They sent it out to units, and they recollected some 15 months later that hadn't been used. They also took some that was stored at 4 degrees, 25 degrees, and 40 degrees in controlled environments. And those were to mimic what would happen if we left it in a cold room temperature versus extremely hot environment over similar periods of time. And then they compared that to new stuff just obtained from the Germans. And what I want to highlight is that when you compare the units that were in field conditions that went out with the unit for training, and then they came back in and probably were in a building for a while and went in and out over the course of 15 months, what you see is that, yeah, the INR is a little bit higher in the stuff that's been in field conditions. It went from 1 to 1.3. But arguably, that is a small change for a product that could significantly impact what our overall resupply requirements are. Small change in the PTT and small changes in the clotting factors. What they did see is that there is a significant change when you leave freeze-dried plasma in a 40°C environment for months on end, because by 6 months, it had gone from an intrinsic INR of around 1 to about 1.6. So in a hot environment, freeze-dried plasma isn't going to last forever, but in a typical environment where it's potentially going to get used and get replenished, this becomes a very nice and attractive option to see. So what we have right now is available under the FDA and for the US Department of Defense is the product there on the left. That is what the French freeze-dried plasma comes in, a giant glass vial. And having had this handed to me on deployment, I can tell you it's about the size of an American football. So this is a large cumbersome thing to shove into my backpack and to think that I'm going to take with on a mission and that the glass is going to hold up. What you see on the right is a picture of Replaz. This is the product that is currently awaiting FDA approval. Replaz was made by a vascular company. That company was then bought out by Teleflex and it's now been rebranded as EasyPlaz. But EasyPlaz comes in a container that is, much more akin to what we normally would think RBCs or FFP is coming in. It holds up much better. While I would never, as a paratrooper, want to jump out with a glass vial, I have jumped out with a backpack full of Replaz, and it all holds up just fine when you parachute on in. So I think Replaz or EasyPlaz is going to be a real game changer for military medicine in that we won't need to rely so much on having the FFP. We'll be able to use this reconstituted freeze-dried plasma. It's easier for us to carry. There's less logistics in trying to get to us. I don't need to worry about the temperature anymore. And this will be a significant change. Where in your civilian practice you may see this is a great option for hospitals that don't have the luxury of being able to have liquid or pre-thawed plasma available to them. Instead, you could have this sitting in your ER for months on end for the rare patient that maybe at your hospital comes in once in a while needing plasma and needing it right away. So that may be the other scenario where we see it. And I've talked with the company and told them that, quite frankly, I think that you'll also see that this starts getting used much like it did in World War II, where this becomes a new topical hemostatic agent that I could pour into a wound and immediately provide clotting factor into that wound. And the nice thing is, I don't know that I need to really reconstitute it if I'm pouring it into a wound that's oozing. I think that the plasma that's naturally oozing out in that wound is going to provide the reconstitution. And that is how it got used during World War II. It was very successful. So I do think we may end up seeing this in our operating rooms as well. The next thing to talk about is PCCs, the prothrombin complex concentrates. And so there's 3-factor and 4-factor concentrates. And the thing to know for each of these is this is, once again, I'm going to tell you an off-label use of this product. The 3-factor concentrates were approved for use in hemophilia patients for control of bleeding, whereas the 4-factor concentrates were approved for reversal of coagulopathy caused by vitamin K. What we're looking at using it for now is just using it in the general population, the general trauma population, because it worked really well for the patients that were on Coumadin and that came in with a brain bleed. And people just started saying, what if I used it for the people that had an abnormal INR but weren't on Coumadin? And those initial studies are what have gotten us to where we are currently. And so what people have seen in a series of studies and this meta-analysis that I have data from showing here is that if we use it for acute traumatic coagulopathy in the absence of taking any vitamin K antagonist, it does improve survival. Now, there's only 3 studies out there. Somehow these 3 studies have already generated 2 different meta-analyses, but both have the same conclusions, which is that there is a survival benefit if we give PCCs. And this is using PCCs in addition to your normal routine transfusion protocol. So what did these studies see individually? Well, they saw that there was a faster time to correction in the INR by almost 10 hours. So I can almost instantaneously correct your coagulopathy, just like if this was being given for vitamin K antagonist, if I give you a PCC. By doing this, I decrease the amount of red blood cells that you're going to get by about 3 units, and I decrease the amount of FFP you're going to get by 2 units. It didn't really change the need for platelets. And then the nice thing was, even though it is going to allow clotting to occur, it doesn't seem to increase the rate of DVTs or PEs. So I can make some incremental improvements in how much I need to transfuse you. And remember, I said for the future battlefield, I'm talking about maybe 250 patients that need surgery that day. If you figure the average patient needs 8 units, that's 1,000 units of PRBCs. So every time I can cut down on the amount of RBCs I need to give one patient, that's more blood for the next patient. So I think small incremental changes really do for combat medicine, or today when we're dealing with our current blood shortage, could have a huge impact overall in our blood supply. So does it matter if you give a 3-factor or a 4-factor PCC? Well, the answer is it depends on what outcome you want to look at. So this was a study that looked at the use of a 4-factor and a 3-factor PCC, and then just did what were the outcomes as far as correction of the coagulopathy, blood products administered, and then other clinical outcomes such as survival, the thing the patient cares about the most. So if we compare the 4-factor to the 3-factor PCC, what we notice is that there's a factor, the rate of INR correction is much faster if we give Kcentra, if we give a 4-factor PCC, and the time to correction is quicker. So if we need an instantaneous correction, it's going to do better. If we're worried about trying to conserve how much blood product we're transfusing, well, there is a slight decrease in the amount of PRBCs and FFP that will end up needing to transfuse the patients. Again, just like as if we didn't give any, it doesn't seem to affect what it does for platelet transfusions. However, for what the patient cares about the most, there's no real difference in mortality. It's still about a quarter of patients that are going to die no matter what. There is a cost differential. The 4-factor is more expensive. Most centers, it's almost $1,000 difference in cost. And so you have to decide for your center what the right answer is. But for military medicine, I would suggest for us, the 4-factor may be better because I can conserve some of those blood products that are already in short supply. So what's coming down the pike with this? There is a phase 3 trial that is currently trying to recruit more centers. And what they are going to be looking at is what is the utility of giving PCC in lieu of FFP as part of the initial MTP that comes up for the patient when you activate your MTP. There is also a phase 3 trial that is about to close out of Oregon Health Science that has been looking at what is the effect of just giving the PCC as part of the initial MTP in addition to the fresh frozen plasma. And so the Oregon study, as I said, should be closing this month, assuming they accrued patients at the rate they expected. So hopefully sometime next year, we'll start to hear about those results. This larger phase 3 trial that is looking for partners for this multi-center is going to be a 5-year study. So this one's a little bit further down the line. But I think what you're going to start seeing is where people are trying to be a little bit more liberal about giving a PCC, not reserving it solely for the patient with a vitamin K deficiency. And then we'll adjust from there to see, how frequently do we give this and in what settings. The beauty for the PCCs are Kcentra in particular. You look at the package insert, it can be stored at any temperature from 2 to 25 degrees Celsius. And even at that temperature range, it's stable for 36 months. So for the military, you can take this forward with you and it's going to be stable and you're going to be able to keep giving it. And even after you reconstitute it, you still have 30 days that you can administer it before you're supposed to dispose of it. So I think we're going to see more and more use of PCCs in this manner. The third thing I want to talk about is valproic acid. And valproic acid, we all know, is US FDA approved for seizures. But there has been a lot of work done on its use for traumatic brain injury, and that has spilled over to other areas of traumatic injury as well. And when we're looking at it for trauma, we're looking at kind of some of its side effects. We're not looking at its anti-seizure effect. We're really looking at its ability to inhibit the class 1 and class 2 histone deacetylase proteins. And what you see from this diagram is that's going to act to that NF-kappa B pathway on junk and eventually affect apoptosis. So valproic acid will help prevent apoptosis. It's going to have some other effects as well. So as I said, the majority of the work on this has been done in the setting of traumatic brain injury, and the overwhelming majority is through Hassan Alam's lab from his time at Michigan and now at Northwestern. And what they have been able to very nicely show is through swine models that by preventing the histone deacetylation, what you do is affect which proteins are getting generated. And this ends up leading to improved cell survival, less apoptosis, reduced oxidative stress, less inflammation, and just an overall better outcome. So this is one of the many studies that they have published on this subject. And this is from a swine model where the pig gets essentially a cranial burr hole and then a defined concussive injury. And they compared just giving placebo, which was saline, versus saline plus valproic acid. And what you see in the pigs is that the size of the injury ends up being smaller at every time point that you study. And you can see that visually on this histologic image. You get a less severe TBI as far as how it gets graded. So think, pig equivalent to the Glasgow-Coma scale, you get an improved GCS. You get less cerebral edema. And all of this translates into a faster recovery, improved survival, and just better outcomes in general. So valproic acid for traumatic brain injury looks like it's about ready. The phase 2 trial has been completed on healthy volunteers while trying to work out the dosing. We're awaiting a phase 3 trial that should be starting fairly soon, looking at its use for traumatic brain injury. It's also been looked at for hemorrhagic shock. And for hemorrhagic shock, what they ended up doing was also a pig model. There's also rat models that have looked at this where they bleed down the pig, delay the resuscitation to create kind of a prolonged field care environment, to use the military term, and then either give head of starch or give head of starch plus valproic acid. And while head of starch is not what most of us are using, hopefully for our hemorrhagic shock patients, it is a convenient model for animals. And so what they have seen is that by giving valproic acid, you are able to decrease the amount of time it gets to a normal blood pressure. You are able to decrease the amount of fluid it takes to reach that normal blood pressure, and you see better survival out to 72 hours. And so the survival curve, this Kaplan-Meier curve that I included here is just from one of the studies that has looked at this in hemorrhagic shock, but they all have very similar type findings where there's a rather profound improvement in the use of valproic acid. And the thought with this is that you are decreasing the inflammation, but you also are, through other studies, they're showing that you're increasing the vascular tone. And so it is having a direct effect on that vascular tone. And that may be why you're decreasing the time to get a good pressure, because you're getting a good pressure quicker. You're not giving as much fluids. And then hopefully you're not overshooting the amount of volume you're giving the patient and the downstream complications associated with that. So while hemorrhagic shock is not as well studied, This is another venue in which people are starting to look at, and I think that you're going to see this in the next 10 years start to creep into our practice because this is a rather safe and inexpensive drug. The last scenario where people are looking at with valproic acid is its use in thermal injury. And for thermal injury, they're creating 50% total body surface area burns on rats, and then following survival, as well as collecting tissues throughout and studying the effect on tissues. In particular, they've been looking at the lung and the skin and cardiac activity. And what you see is valproic acid decreases the microvascular permeability, which improves the pulmonary edema. There's less inflammation, and there's better survival. So again, much like with hemorrhagic shock, there's not a ton of data on its use in thermal injury, but the mechanism, it seems to be working the same similar mechanisms to what we see with TBI, and with the profound improvements that people are seeing with it. It's low risk, it's been around forever. We know what its risk profile is. It seems like this is something else that is rapidly reaching its time to become part of our trauma resuscitation armamentarium. So I'm going to shift gears here at this point and kind of go from talking about things that were resuscitation in a syringe, and instead talk a little bit more about how we bring modern critical care further forward. Because I think that's where the next giant leap in care is going to be. When we think about the future battlefield, there's a lot that we're pushing forward. In medical care, there's a lot of pre-hospital stuff that we're doing. But to truly get better outcomes than we've seen during COIN, the counterinsurgency operations, I think we're going to have to bring state-of-the-art critical care closer to the point of injury, at least to our rural 2 hospitals that are just set back from where the injuries are occurring. And so the first thing I want to talk about is bringing ECMO further forward. And ECMO shouldn't be a stranger to anyone, especially after the last 2 years of COVID. I think even the public knows what ECMO is now when we talk about it. But I just want to highlight that the first reported use of ECMO, it was on a trauma patient. The first reported survivor was a trauma patient. This was something done for trauma. This was for the trauma ARDS patients. And while we currently think of it as for ARDS, as a trauma surgeon, I want to plant our flag back in the ECMO territory and say, we need to think and own this process a little bit better. One of the downsides to being able to talk about the use of ECMO in trauma is that in the international registry, there's no code for trauma. Instead, there's a category variable for post-op and trauma ARDS. It's an all-inclusive thing, and so we're not easily able to separate out of the extracorporeal life support registry data the trauma patients. So instead, what we're left with is a series of small and maybe moderate-sized single institution studies. These studies are almost all epidemiologic in nature, in that it's just somebody saying, this is what we did and this is what we saw, and doesn't really have a comparator group to say, is what we did the right or best thing? But I'd like to share with what some of that data shows. And this is all taken from a recent systematic review. And what we see is that ECMO for civilian trauma is basically used for adults, predominantly males, and they tend to be young. Now, those 3 things are somewhat intuitively make sense, especially that it's going to be males in a younger population, because that's the trauma population in general. The next 2 things should make sense as well, which is it's generally used for blunt trauma, and patients generally have an injury severity score of 38. So these are people that have multiple regions of the body that are injured, they're rather significantly injured. And that kind of makes sense as well. The hard part about taking this data, then applying it to the military, though, is that blunt trauma accounts for most of the civilian use of ECMO, whereas blunt trauma is not the majority of what we see in combat. What we see is IED blasts and gunshot wounds, which are kind of a different mechanism. And so we need to be a little bit cautious in applying whatever we know about civilian trauma and ECMO to the military population, but I still think it gives us a good starting point. We know that ECMO for civilian trauma generally is put in at a median of day 5, although there is a small portion that get cannulated in the first 24 hours. Generally, VV ECMO is sufficient, and most people for civilian trauma are only on ECMO for 10 days. So why this is important is because this is speaking to the fact that if in the future battlefield, people are holding on to patients for prolonged periods of time, then reserving ECMO for the Role 3 hospitals, the larger ones, like, in the most recent years, think Baghdad, think Bagram, reserving it for there and the team flying into there and then cannulating, this may not be the best plan. Because if we're holding on to people for prolonged periods of time, if we want to save lives with this, we may need to move this forward. What we see for civilian trauma is that survival for people that need ECMO after trauma, it's 70%. That's pretty good in my opinion, and says that we need to do more to look at this and better understand what's going on and who best to use this for. So the military has used it, and I'll tell you that there are almost as many military papers on the use of ECMO in combat. I think there may be more than there are patients we've actually used it on. So we've reported on a total of 20 patients that have received ECMO for combat injuries. They are about 10 years younger than the average civilian use. But again, this is military fighting age is 20, so this makes sense. Half of the people that have gotten ECMO after combat injury were from blast injury. A little over a third are from gunshot wounds, and the rest are from other mechanisms. So this is a slightly different mechanism of injury pattern than we see in civilian trauma, but this mirrors what our injury patterns are for combat. And I don't think the mechanism of injury is a critical thing. The critical thing is that we make sure we know which patients have ARDS or are going to develop ARDS, and then cannulate at the right time. And for military use, the survival is 87%. That is significantly higher than the civilian literature, but there's a massive survival bias because even at the height of the war, when we were doing the majority of our ECMO, the transport team was coming from Landstuhl in Germany to Bagram, to Baghdad to cannulate the patients and fly them back. So you had to live long enough for the team to get there, and that's about an 8-hour flight. And when you add in some time for them to mobilize to get off the ground, that speaks to, you had to do better to begin with. So the survival may be higher as a result of a survival bias before cannulation occurred. But what this does say is that we did get good results with this during counterinsurgency operations. So there's no reason to think in the future battle space that we can't use this and get good outcomes again. Right now, the military, at least the US military's capability, is based out of San Antonio Military Medical Center. And these are their case numbers for transport versus actual ECMO patients for 2013 through 2019. I don't have their last 3 years or 2 years worth of data. I'm certain with COVID, these numbers shot up much higher. But what I want to highlight is this is the sum total of what the military's current capability to train and sustain people on being proficient ECMO is. And these numbers are adequate to maintain the small teams we have now. But if we want to push this further forward, we need a whole lot more people trained on this. And this gets into what we really need for in the future. So I think we do need this capability. We do need to figure out how to make the equipment smaller, ruggedize some of it so it can survive better in our environments. And we need to get this out to at least some of the Role 2s. We need more research done on what is the best use for it in trauma, which patients are going to do well, which ones are not. Because for the military, if I'm going to use this, I want to know that it's going to be successful because it's going to add an additional layer of complexity to moving the patient through the system. And if we know the patient's not going to do well despite ECMO, I probably shouldn't use it. The other thing is we need greater exposure to ECMO patients because we need the team education, the team training, we need to maintain the proficiency. And this is where our, civilian partners can play, in my opinion, a great role. Right now, we have 7 civilian centers that have Army personnel embedded at it, working there on a day-to-day basis. But that is just scratching the surface of the people, just from a physician alone focus. That's less than 10% of the force that is getting the chance to, work with ECMO patients and understand how to manage these patients. So we need to figure out ways to widen that experience and to truly have teams fully prepared to manage this. The other place for moving critical care forward, I think, is renal replacement therapy. And I won't bore you with, civilian data on it because this is just, frankly, taken for granted. This is just a part of what we do for critical care on the civilian side. For the combat injured, we know that 1 in 3 of our combat injured patients is going to have an acute kidney injury. And we know that an AKI causes a 10-fold increase in mortality. And yet renal replacement therapy has largely only been available at Bagram, and for a period of time it was available in Baghdad. So it has not been widely available, in my opinion, especially not far forward. People did early on talk about placing peritoneal dialysis catheters, and there's one very small series that talked about 4 patients that they got some success with. Really, CVVH, which is what you see pictured here, would be, I think, the better option, although peritoneal dialysis does have some benefits. But currently we only have that available at our Role 3 facilities, and we haven't really studied it very well. We know we've used it, we know that it will work, we know we can get some good outcomes with it, but defining when to use it and how do we push this forward, we're still not there at this point. So what do we need next for renal replacement therapy? Well, much like with ECMO, we need, to shrink the equipment. We need to make it ruggedized. But we, just like with ECMO, we need greater exposure to renal failure patients so that we get the team education and the team training. Right now, the CVVH is used at several of the large military medical centers, but many of the smaller ones, and certainly at some of the military's community hospitals, that it maintains, that exposure, that training is just not there. And even in our larger medical centers, it's largely being driven by the medical intensivists and the nephrologists, which means the people that are actually further forward, which for us is the surgeons and the CRNAs, and starting to be some of our anesthesiologists. They're just not getting the exposure on the civilian side or backstage side that we need on managing these patients to be proficient at it. So what I think you're going to see in the future, if we do face large-scale combat operations, is you're going to hear numbers that are going to be vastly different than what we're used to from 20 years of fighting counterinsurgency and people that frankly aren't armed or equipped the same way we are. Once we fight somebody who's a near peer, this will be a very different fight. We're going to need to figure out how to better streamline our resuscitation. That may mean looking for strategies like resuscitation in a syringe. Everyone keeps looking for that magic drug. That magic drug doesn't exist, but if we are able to, through a series of small medications, make some significant changes in how much blood product we need to transfuse, we can get some slightly better outcomes. That's going to pay dividends. Those small things can make a huge difference. And then as we're looking at that, I think we need to be looking at how do we get ECMO, how do we get RRT pushed further forward. There's a lot more that I think we need to do and we need to prepare for the next battle. But I think these are the things that, for those of you that are civilian, have a direct impact on what you do on your day-to-day basis, and are things that, for the resuscitation, are things you're going to see in the next 10 years. And as far as ECMO and RRT, they're the kind of things that if you're partnering with the military, these are things that we probably, could greatly benefit from those of you on the civilian side that do this on a more frequent basis. With that, I'm happy to entertain questions when we get to the question and answer session in a little bit.
Thank you, Tim. And what we'll do, because I'm still waiting for Amos to, actually he's going to send me a recording of his presentation, and that I'll play that between now and the start of Charlie's session later on this afternoon. So if we can open up this session's Q&A. Got one question in the chat, sent in by Michael Wu to Dinesh. How often do you see, how often do you use E-wave variation to help diagnose tamponade? He's found that it's fooled multiple times. Just looking at the RV-RA collapse and subsequent formal TE showed no variation, therefore not concerning for tamponade.
I think that's an excellent question. And to answer it, I guess the important thing to remember is that tamponade really depends on the loading conditions at the time you make the observation. So if a patient is hypovolemic and their venous pressures are low, then the difference between their right atrial pressure and their pericardial pressure is exaggerated, and you will be able to observe those differences in findings or respiratory variation in that exaggerated way. If you fluid resuscitate that patient to a very generous amount, then eventually the right atrial pressures theoretically should increase, and the difference between the right atrial pressure and the pericardial pressure should not be as exaggerated. So you may not see the same degree of variation with respiratory, or would not see the same degree of respiratophasic variation. That's also to say that if you have high right-sided pressures for an independent reason, like pulmonary embolism or pulmonary hypertension, you also may not see that on the right side. I do think that that E-point variation to assess for the exaggerated respiratophasic variation is a great way to do things, but tamponade is a very load dependent finding. So it's also possible that you made an appropriate assessment at one time, appropriately resuscitated the patient as part of that patient's care in the correct way, and then on subsequent exam, it was just not observable.
Thank you, Dinesh. I'll just ask one to Ali Dalton, which was submitted by Barbie Lopez, and then I'll offer it up to Peter to ask the next question. So Dr. Dalton, one of the highlighted causes of burnout that you mentioned was lack of respect or appreciation from administrators. How do we as a group change this dynamic of non-clinical administrators dictating what our care is supposed to be for patients?
I mean, I think this is a great question because it's something that many, if not all of us, are dealing with on a frequent basis. I think one of the things that was probably best highlighted in the Fisher study was trying to get those of us who are clinicians and are physicians into the leadership roles within the healthcare system, so that there is that understanding of the clinical aspects of medicine when making decisions as a healthcare system. However, unfortunately, that does take time. So one of the things that I think I would utilize, as I utilize sometimes with my non-clinical patient families as an intensivist, is invite our administrators to the bedside. They may or may not be willing to join us there, but have them come experience what we do on the clinical side, give them an understanding of what the clinical aspects of our jobs entail, and that may be able to help inform them when it comes time to make decisions.
Thank you, Ali. Peter, would you like to present the question?
Sure. By the way, thanks, Ali, Dinesh, and Tim, wonderful talks, very insightful. So Tim, I'm more, sort of, there's quite a number of us who have some military background, and I'm interested to get your perspective or ask sort of more towards the state of modern sort of combat casualty care. When we look back, right, in probably in Iraq and then Afghanistan, a lot of the major developments that were, I think, in my view and others, revolutionary, were, for instance, even the creation of forward surgical teams, right, to bring basically surgeons and state-of-the-art resuscitation as close sort of to the front line as possible. That was revolutionary. I mean, without a doubt, right? Because if you, I was, I'm not in the U.S. military, but I was in the Austrian military, which was very kind of World War II warfare, against the Soviets in a way, and it was very hierarchical organized, right? So you did not see a surgeon until you were at the brigade level, maybe, or at the battalion level. So in sort of an evolution to this, damage control surgery, damage control resuscitation, these were concepts that 20 years or 25 years were just not taught, right? I mean, we are old enough to remember, right? Level 1 trauma, we resuscitate with 3 liters of LR, warm LR, right? That was the, blood was just, the amount of change in resuscitation and the level 1 trauma care has been nothing short than dramatic. So let me ask you, what is the current evolution or thinking of, for instance, how the US military thinks about forward surgical teams, damage control surgery, damage control resuscitation? And one side comment, there's always a saying, right, that the US military or, the NATO always fights sort of the last war or prepares for the last war, right? If you think about sort of the next evolution, and of course we now have a major confrontation and war in Ukraine, but I think the US military was planning for a major warfare in the Pacific theater, which is in all likelihood much more naval. So if you could comment about sort of naval combat casualty care rather than sort of land-based, I think that would be quite interesting.
Yeah, thank you, Peter. I agree. We always fight our last battle, and that is why usually the senior leaders get relieved within the first year of the battle, is because they're fighting the wrong war. The current thing that we're looking at talking about is our austere surgical teams. So how do we push the capability further? And historically, that has been a very small, carefully selected group of people that go out into these groups. And they have one, for the US military, they have one paper out there that talks about the last 25 years of their existence, what they did. And the number of cases they've done is very small, which is great because of who it was they were taking care of. But what we're saying is we may need something different where more people need to know how to do that. And this is constantly in evolution and constantly in discussion, on the US side and with NATO on what we need to do. Rocky Farr has a great book that's available for free online that talks about this, the death of the golden hour and the return of guerrilla medicine. And, he is right. I spend a lot of time reading about what medical support was provided to partisan efforts during World War II and what that looked like, because I think that may be what we really need to think about is how does one person with 2 other medically trained people do something underground and support others? And how do you change the rules? I think we've become very rigid in what we want to do and to define what success looks like. And that will be one of the challenges. The issue of talking about what does it look like if we're island hopping in the Pacific is a huge thing. If you are carrying your casualties with you from location to location, it is going to slow you down. And we're going to have to leave them somewhere. And so we need to figure out how best to train people. And then what is considered an acceptable level of care. And so we keep talking about prolonged field care. We talk about how do we train our medics? How do we make more of our EMTs be paramedics? How do we make our paramedics to look like PAs? How do we make our PAs look like physicians? And bumping kind of everyone up a step. And I think that's the challenge that we grasp with currently is what is the appropriate way to do that so that we try to provide what is standard of care, but at the same time recognize standard of care is always local. And the local standard of care may need to change in some of these scenarios.
Can I ask you a follow-up question sort of on this? Because I think this is very challenging, sort of trying to find a good solution. Because you may also, in counterinsurgency operations, right? It was largely led by light infantry and special forces, and you would have a need for a smaller number of highly trained either EMTs, paramedics, or doctors who also needed to be able to qualify, get Ranger qualified or even special forces, right, at that level. That is by far a very small minority of doctors, of physicians, of EMTs who can simultaneously be very good at resuscitating patients, but also fight, right? I would not survive in that environment, let's be honest, and many of us won't. And so if you have larger scale combat, you run into the problem. You have world-class, for instance, surgeons, anesthesiologists, EM physicians, but they really don't know how to fight, right? And would be basically victims within the first day. So what's the military thinking about how to solve this?
I think if we truly ran into a prolonged war against a near peer, it becomes an all-nation effort. And so I think you'd end up, number one, seeing something akin to like what we used during the Vietnam War, where there's the Berry Plan, where, like you're saying, a lot of people are getting, not necessarily drafted, but, it may feel like that, where they're getting that tap on the shoulder saying, we need your help. And I think those individuals who are getting plucked out of, their highly specialized field, put in a different environment, we don't want to put that person far forward unless they are a prior service person who is proficient with their weapon, that understands the local language and customs, and that's going to, have a chance at succeeding. So I think those technical experts are a little bit further back. So if you look at what happened with GWAT, we encouraged, the experts to come to launch duel for a week, a month, 3 months, and be the visiting scholar professor. And I think you'd see something like that because we're looking at a much more layered and complex level of evacuation routes and levels of care, in which case our current doctrine of we have a role 1, a role 2, a role 3, a role 4 is blown up, and there's a lot of sub-level stuff. And so we would push someone to the level that they're comfortably able to succeed at. That far forward person is going to be the person who's like on active duty like myself, where it's, listen, you're the person that's still going to the range. You're the person that, is still going out on the weekend and rucking and maintaining your proficiency. And the other thing is it's a, self-select process now. To a certain extent, you have to raise your hand. And I think it will remain as something where people have to raise their hand. Luckily, there are always young men and young women who are willing to raise their hand. They don't always know exactly what they're getting themselves into. But there's people willing to rise to the challenge, and I think we'll rely on those individuals that are willing to do it, and then hopefully there's a few old salty people around. Maybe I'll be one of them to sit there and offer advice on, well, back in my day, this is what we did.
Thank you, Tim, very much. Just one final comments. I think the evolution of strategic medevac and critical care transport is without a doubt also, I think, a major improvement, right? And I think a driver of improved outcomes. And also that now active duty military medical personnel is embedded in in civilian hospitals like ours now, and as was the case has been at WashU and St. Louis University for a long time. I think that just makes a lot of sense. So thank you for your comments. Hand it back to you, Jeff. Thanks.
Thank you, Peter. Jason, I think you had a question you'd like to ask. So over to you.
Yeah, question for Allison. And before that, I'll just make a comment to our attendees, and that is, we may not have all the time we need in the Q&A sessions to get to everybody's questions. We'd welcome people to go into Doc Matter and post questions there, and we'll facilitate continuing the discussion. But for Dr. Dalton, I'll just ask, I think one of the challenges we have with building such models of these peer support groups and trying to intervene with people who may have been adversely affected by an event is doing it in real time. There's always so much production pressure, or the OR schedule's got to continue moving, and everybody has something to do. How do you feel you've done in terms of trying to do that more in real time? Any pointers or advice for those of us on the call today about how to be better at that?
Sure. Well, I'll start with the caveat to say that the initial implementation of our peer support group at the University of Chicago did not have an actual in real time implementation. Our initial activations were really get the information to us, and within 24 hours, we'll have someone reach out to you. So we really kind of relied on the people who were in the room at the time to do things like group debriefs, especially with our trainees. Luckily, over the course of the last couple of years, in July, we were able to implement an immediate access peer support system where we have one of our peer supporters who has a pager at all times, who can receive those pages for immediate access to a peer support person, especially right after or even during an event. There are obviously still things that we would like to improve upon. There's still issues with how do we provide care? How do we, help people to not have to go into their next trauma case at 3 a.m. when it rolls through after they've just had a perioperative death? So there are certainly things that we can work on, but we've been trying to at least have access to someone that they can speak to over the phone within about 30 minutes or so.
Thank you.
Thanks, Ali. I'm going to ask a question basically to all three of you, or even Peter, Jason, whoever wants to answer. So when you look historically at the Yerkes-Dodson law curve, where we have performance and arousal or pressure, giving the two, and you get to a certain point where the pressure or arousal gets to the point where your performance drops. How have people managed that situation? What have people done to reduce your drop in performance as the pressure mounts?
I suppose I could probably start with this one. I think one of the things that I've personally tried to do is, unfortunately, this is the best example of kind of a mindfulness type activity, is really just take a moment before I do anything else, if possible, to take a breath, look around me, appreciate where I am, appreciate the priorities of what I need to do next. And without doing anything, even for a brief few seconds, assess what's happening around me in order to recenter myself and then to be able to move forward and make the next appropriate, mostly decisions and best next judgments in what we have to do next.
Absolutely. I mean, that's what the military used to teach us, was you take a time out, you step back, and then you re-engage. Otherwise, you can get too task focused and forget the bigger picture. Great. There's a few more questions, which I'm just aware that we are running out of time for this Q&A session. Maybe I could ask Dinesh to respond to Mira's question in the chat. Ken Wilson has got one for you, Ali. And then just probably one question while we give this, the last orders sort of questions before we close the Q&A is to Tim, and it's from Woody Moss. In terms of PCCs, what is the cost relative to giving similar amounts of FFP?
So the institutional cost really comes out in the wash with what you're paying for the PCC versus if you're saving 3 units of RBCs and 2 of FFP. It's about an equivalent cost for your institution. I would argue from a purely economic end, if the patient is surviving and having less complications as a result, it's probably actually making you money in the end because you're going to get them discharged quicker and they're going to do better. But from just a pure resuscitation end, it's essentially cost neutral.
Thank you, Tim, Dinesh, Ali, Peter, Jason. I think we can call the Q&A to a close. What I've actually received whilst we've been underway is a recording of Amos Sim's presentation. If it plays, I will play it next. And obviously we will reconvene at 13:15 for Charlie's session. So please watch it if you're interested. It's going to be a recorded presentation. So I will share my screen and see you all again at 1:15. Thank you.
Jeff, I don't think we can hear him.
Did you say you can't hear it?
Correct.
Ah, okay, let's see if I can change the volume.
So, ladies and gents, thank you for the invitation. It's a real honour to be asked to today. I would have liked to have been there in person. I would have even liked to have been live, but unfortunately, IT doesn't always work with us. So, my name is Major Amos Sims. I'm a member of the British Army and the head of the Academic Department of Military Mental Health here in the UK. Day to day, I work at King's College London. The slide you can see at the moment is one of the buildings of our wonderful university. It's a university with a long history of conducting military research. So today I'd like to share with you the UK Armed Forces strategy for providing support to our medical personnel. That said, the strategy that I'll describe to you is similar, very similar to the strategy we're implementing for other medical personnel on their return from operations. Of work where patient care may suffer, but also at home. The stresses in the UK Armed Forces, much like your own and your own medical professions, put significant pressures on the families. For the model that we're going to talk about today, caring for the carers, this is the starting point for this new framework within the UK Armed Forces. So the model I'm going to present was conceived about 2 years ago. It was just before COVID took hold in the UK. My department were carrying out research on the existing strategies that we were using to support service personnel on the return from operation. And whilst there were a number of positives, we always felt we could do much, much better. Now, as we began to formulate this model, COVID took hold. So we were approached by the NHS who asked for our support in supporting their medical staff. So really the first iteration of this new supported model has become very medically focused, but that was never the original idea. It was for the whole force, for all of our service personnel. And the old strategy we used to use for supporting people after a long period of time doing a stressful thing, it was called decompression. And to be really honest with you, it was, you could say it was no more than spending 48 hours so in a third location, somewhere between the war zone and home. And yes, there were a series of briefings where we tried to talk about what may happen in the weeks and months later, psychological, the sequelae of stress. There wasn't a great deal of conversation about discussion and talking about what they'd all been through. Now, the unfortunate truth about this was that a great many service personnel didn't value the decompression. It was seen as something of a tick box exercise. Now, research into this found out that there were benefits, and those areas that were beneficial were feelings validated. Now, this is understood but not judged. Also, not medicalizing everything. Distress doesn't need to be medicalized. Peer support comes through time and time again within military research as being a really high priority. We like to talk to one another rather than people coming in from outside. Organizational support. Again, the idea that the organization care and they will provide some level of intervention, identifying what we've been through. And finally, the idea of a sense of value. This is a theme we've researched many, many times, and you cannot underestimate how important it is for an organization to make their employees feel valued. So these were the areas that we identified as good points as we started to wonder how better we could provide care. And within that, we also started looking at what was causing distress. What were those problems? Now, as I say, because COVID was the main effort when the model was put together, we looked at the stress within the medical professions with a particular focus on the pandemics of the 21st century. The truth, though, that a lot of the themes that came up in the pandemic were themes that have been coming up for years in all of the medical disciplines. A different story, but the same theme of stresses. Now, these are stressors, things that cause distress during the event and then long after. And that's the thing. Those things that people go home, ruminate about, worry, could I have done this, should I? Rather than spending time with their families, they're thinking about work and life. And we came up with these 5 things, and they're very broad. But the idea here was to give ourselves a bit of a handrail. Because we had an idea that we wanted to generate discussion, get our service personnel, our medical personnel starting to talk about their experiences. So rather than just saying, let's talk about what we went through, give a few handrails, things that evidence suggested were worth talking about. Now, we settled on 5 here, sort of personal and professional challenges, things like communication within an organization, the agreed time on task, having the right kit, vulnerability, personal protective equipment as an example, hypervigilance, being aware of in the pandemic, of being aware of other people becoming unwell, and families, death and suffering, time and time again, a sense of powerlessness within this compassion fatigue, which you will have already heard about today in far more detail, but caring for the patients and the families, and perhaps even times guilt at not doing what we would have liked to have been able to do. Expectations. There's lots of thoughts that go around about what does the future have in store, and there's an awful lot of uncertainty. Where do we all go from here? And within that, there was often the idea of this shared experience that you've had that others won't really understand, yet there'll be questions and questions about what did you see, what did you do? And finally, potentially morally injurious events. This is the area I wanted to maybe spend a little bit more time on. So this is an area of interest. It's one that I'm being asked to comment on regularly. Now, it's a concept that's always been around. It's always been around. For those that like their Greek classics, you can go back to plays like Euripides, and there's lots of moral injury there where the mother has to decide about does she fight the enemy, or in order to win, she has to kill her children. All bits and bobs, so all morally injurious stories. But the concept was only really the subject of scientific study from around 2009, and that first paragraph is based on the working definition from LIPS in 2009. And this is about, as we say, about perpetrating or failing to prevent or seeing things that go against your moral beliefs. Now, the second paragraph was added following some further examinations by Shea in 2014. And is more about the idea of being betrayed, being let down by colleagues, leaders, or trusted authorities. Now, the whole moral injury, moral distress concept. Now, look, given that morals are a system of beliefs, they define rights and wrongs, good or bad, and morals have this social value, and they create normative expectations. These are beliefs about what people should do, and so therefore we have expectations about what they will do. And the moral dilemma, and whatever it looks like, it may be where there's a conflict between two moral values, or that acting in a way which meets one fails to fulfill another. So the conflict between loyalty and respect for life, perhaps. Or that the dilemma is that even following this, this moral pathway, harm will occur regardless of what we do. So the whole idea about the moral injury. Moving on, what is the impact of this? Well, I guess the idea about the research, starting to define it, starting to look at it in more detail, we may be starting to appreciate a little more, certainly as a therapist, the impact that this can have. And if we said that moral distress, the moral concept, is all about violation of normative expectations, these are the very foundations that we base most decisions on. This is going to provide, evoke a really strong emotion, and with it, we may see lots of intrusive thoughts and ruminations, and really the mind is going round and round this thing that doesn't make sense, that shouldn't be, it cannot be. So we go round and round. There may be negative self-appraisal, the idea that if I believe that I've got some part to play in this, I'll start to judge myself particularly negatively, and we have a range of emotions that may fall out of this: guilt, shame, anger, disgust, grief. And of course, with all of these, too much of any of these things, we all have a cognitive capacity, we can only juggle so much. And with this, we're treading a path where we may lead to reduced functioning. Again, the department in which I work here at King's College London, an awful lot of research has gone into this, and it's sort of mapped over to a lot of the other studies. And we have found really strong links with moral distress leading to PTSD, to depression, to anxiety, lots of hostility, lots of anger, and again, as a therapist, if the client, if there's a lot of anger within that presentation, that's sometimes quite difficult when you're trying to treat. It's keep someone's distress very much alive. Lots of links with self-harm and suicidality, all this frustration within, and maybe a lot of guilt and shame. What we have found, and thinking back to the original two paragraphs, an awful lot of conversation about moral injury seems to talk mainly about the sort of the transgression, things we saw that go against our moral belief. But a lot of our military research, and I've just conducted a pretty sizable piece of research within the military and medical population, it seems to say that there's a stronger association with betrayal. So those that talk more about betrayal, being let down by the organisation, there's more of an association with poorer mental health. But all of the research always points to social support. Now, why would it be that social support, of all the wonderful things you could do, there's something about social support, about being with others, sharing this thing, that is a strong mitigating factor. So we just, a couple more things to mention about moral distress. This has become quite a big thing within the British Medical Association. They've produced quite a lot of documentation about this. They really want the medical professions within the UK to look at this and wonder, is this something that we're subjecting our colleagues to? As you say, the stamps here, they've got their stamps, moral distress, where professionals identify action to take a constrained, and here we are, situations where behaviour doesn't align with principles. I think the thing to think about with moral injury within the medical profession, it comes back to this normative expectation conversation. So in patients who trust their carers, they will have a normative expectation that they should keep them from harm, so therefore they will. And then staff who trust their care providers, their bosses, they will also have a For example, a normative expectation that employers should provide the right kit. And so therefore they believe that they will. And when expectations are met, there's lots of trust and confidence and hope in the future. But where this is fractured, we often see all the symptoms we talked about before, all those presentations, lots of anger, frustration. Now, a little more detail perhaps on this theme before moving on was the research we carried out recently. How big an issue is this? Well, the research amongst the Defence Medical Services, 78.4 identified with this. Now, that's not saying that they all became unwell, but they all identified with this as a theme of distress, something that upset them over the course of their work. And there are 5 themes, and I think just to quickly talk about these themes, again, there were themes within this that suggested being involved in activities or seeing things that go against the way we believe the world should be. But many of these areas point more to betrayal or a perception of betrayal. You know, in an organisation, when there are not enough staff, could I, on the ground floor, think that they don't care? They don't care that I've only got, you know, 1 member of staff, or that, you know, there's no time in between, you know, cases coming in the aesthetic room. It could be absolutely anything. So these are the themes that were coming up time and time again. So now talking a little bit about this model. So we did all the groundwork to identify what was already good, what we needed to do, the needs evaluation of sort, what would really be important about a new model. And the key area that everything comes back to is significant organisational buy-in. And the reason I say that is many strategies currently being used across organisations in the UK, organisations, no names mentioned. You could say a lot of their strategies nowadays are quick fix. They're very emotion focused. They place the emphasis on the individual to improve their health. And when you stop and look, most of the slots, many of their stresses are organisational in nature, yet it's all about you fine-tuning your ability, doing a bit more relaxation or mindfulness or yoga. So organisational buy-in starts with comprehensive training and providing adequate resources. The reason we mention this in our program is because a caring package becomes somewhat meaningless. I think if we don't actually give our guys the tools to work with, it's simply not good enough. The model then starts to talk more about stigma. We'll talk a little bit about the leader's role in this. The model requires leaders to take a full part in the program, organising the teams, taking part in the conversations that I'll describe a little bit later on. We need a buy-in from the leaders. Again, a number of organisations that we looked in, leaders sat over here, and yes, there were lots of signs and you know, where to seek help. But the two weren't connected, and we need to encourage our staff to seek these help, to say that I trust them, I believe in them, so should you. The help seeking is one of the problems we have both in the UK Armed Forces and within our medical populations. We have a real problem with help seeking. People who even know that they're unwell, but are unwilling to seek that conversation. Now, the model promotes coping, which I'll talk about in detail in a few moments, meaning-focused coping. And again, the model is all about signposting. Again, but this was quite a big part of this. Many models that we were seeing were placing the emphasis on mental health, on psychiatry, psychology, nurses, to deliver this, to be the ones who were talking. And we were saying absolutely not. This is a leader-led model. It's all about leaders engaging, being visible. And then the mental health specialists are downstream. Yes, in the meeting that I'll describe, introduce them, say they are here for you, but they stay away. People like me, I stay away. I'm not the person you need in talking to your organisation in the first instance. So the leadership. This is a big area. Really for us. Now, my department has carried out so much research and leadership over the years. All of the research that we carry out in the front line, whether it's Iraq, Afghanistan, Sudan, and we've done this again with our medical personnel in the UK, and it's repeatedly found a greater association between poor mental health and perceptions of leadership, i.e. perceiving leadership to be poor, than with combat exposure. So in short, it would appear from a lot of our work that leadership is having more of an effect on mental health than being shot at. Now, of course, there were times that's not quite the case, but looking at the entire population, it's the same for group cohesion and morale. These are the things that are having a significant impact on our personnel's mental health. And that's something we can absolutely get in amongst. Now, we explored a few leadership models because I think once again, when we first started looking at this, a lot of the models and subsequent conversations with our civilian health services, they were all very keen that the leaders stayed away, and this was led by psychology, which I absolutely do not agree with at all. So we were exploring leadership models that would complement this, and we have compassionate leadership, the themes of attending, understanding, empathizing, helping. It's a leadership model that we're talking an awful lot more about. There's always good literature about it. It has sort of innovation at the heart. The idea about asking our personnel to start to talk and learn and share experiences, and that is absolutely at the heart of it. So if you were to read a little bit about compassionate leadership and then map onto what we expect a leader to do in this particular example, they sort of map over. Now, we want the leaders to take centre stage with this. It's not an intervention to be delivered by mental health. And the leaders they'll know their organisation. They will put people into groups. The idea is it's a leader-led, small groups, one leader talking to a dozen or so colleagues, and leadership goes all the way down. So, it's not just the people in the top corridors, it's all the way down. But what we're asking them to do is to be visible, to be invested in a conversation, to be accessible, and to sit and listen. And there's a simplicity to all of this. There's a real simplicity and meaning-focused openness. The idea that I sit down with you and ask you how it was. Genuinely, how was it? How was this thing? It's not psychiatry. That is a good leader doing what good leaders do. It's what we often call the first conversation. The leader will also talk about, it is okay to be upset about things, that to talk about this might lead to you feeling a little upset. But if any of those happen, look on the back wall. There's all the specialists. There's your welfare. There's your padre. There's your therapy. There's your second conversation. Go and talk to them. We're trying to improve the joining up with a lot of the interventions in the UK Armed Forces. We have people who are distressed, and we do have a relatively good, but no, and part of them should say we have a absolutely wonderful mental health service. But putting the two together is often quite difficult. We want the leaders to take a very active role in that. Skipping forward. Now, the coping side. So I guess this explains the intervention. Now, we already, when we first started putting our strategy together, we spent an awful lot of time looking at coping, ascertaining what strategies were people using, what were most acceptable, what were achievable, what were the most effective. And this is always going to underpin what we would attempt to do as far as trying to give our personnel skills to help them deal with what they've been through. Now, there's a great deal of research on emotion-focused coaching. So that's many things, including meditation, distraction, positive thinking. And there are benefits, wonderful benefits, there really are. It tends to be very, very good in the short term to alleviate distress. However, and the word was a bit of a however, at times the gains were found to be short-lived. Not always, but there were times that it was found to be short-lived. And there were times that it was also found to be associated somewhat with avoidance. So there's a thing to deal with. And sometimes focusing only on dealing with the emotion, well, the thing is still there when we stop doing the distraction. Problem-focused coping, problem-solving coping, I should say. Again, there's a problem solver. Again, wonderful research, of course. If we can identify and break the problem down into smaller chunks and solve it, of course that's going to help it. But sometimes there is no quick solution, and sometimes there's no solution at all. There's nothing can be solved with this. Which turned our attention to meaning focused coaching. Now, there's been a real proliferation of research in this area in the last few years, but all the research always seems to say there hasn't been much in the past. It appears that this was an area that we didn't really look at too closely many years ago, and I can't understand why. But this is a strategy which is really all about maintaining and restoring your sense of purpose and meaning. Now, making sense of an event and the part we play in it, acknowledging what we wanted to do, what we tried to do, what we did do, what we couldn't do. This is all seems to be important in trying to make sense of the thing, of what happened. There's equally an awful lot of research that talks about that there's a loss of personal meaning often following trauma, where the world no longer makes sense. What I believe to be true doesn't really fit anymore. You know, I always believed I was safe. And now I'm not too sure. I always believed I was a good therapist. And now, that last case was an absolute shocker. So we know that can have a significantly detrimental effect on personal functioning. And the idea that getting people to understand more about what happened, the part that they have to play, and rather than going home with just their own perspective and maybe ruminating, going round and round, looking at it from the same angle, all of the meaning-focused coaching is talking about trying to generate a more global understanding. And it sounds so simple, and of course it is. It's the idea of sitting down with people who went through a similar scenario and just talking gently about, how did we feel it went? Now, this isn't critical incident debriefing, because it's not about a specific incident or not scoring. It's about us talking at the end of a week that we would often do over a beer, perhaps. Although when we first wrote this, we were all in the middle of lockdown, so that wasn't happening. There's a simplicity to meaning-focused coaching. And I wonder whether that's why it's been missed, or whether, because it actually requires an awful lot of investment from an organisation. It's a little bit different than giving you a mobile phone app to help you with your relaxation, to actually take time to sit down and talk. Of course, leaders are phenomenally busy, but one of the areas when we first brought this into the military, there were a number of leaders who came forward and said that actually this is wonderful because it gives me the time. I've now got protected time to talk, whereas before I may have always wanted to. I never truly had the time to sit down and talk to my guys about how are things. So meaning-focused coaching clearly became the centerpiece for this idea. And when you stand back and look at the model, it's a real simplicity. A leader standing front and center, addressing whoever is in the room. This is what we did, this is what our aim was, this is what we achieved, celebrating success, and then saying, let's have I'd like to have a conversation like this, I'd like to learn from it, I'd like us all to understand. And then saying, of course, there might be things that we find upsetting, but today isn't about therapy. If there's anything that upsets you, if there's anything that does upset you today, but when you go home tonight, you're trying to watch some TV show, I'll think of a US TV show, it's NCIS. I actually met someone from NCIS. I always thought that was just make-believe, but there we go. But you can't focus on the TV show. You're too busy thinking, well, that would be the indication that person requires a second conversation. It might not be psychiatry. It may be with welfare or a friend or padre. It's about getting this, it's generating conversation and prompting people to sort of talk. So the meaning-focused coaching, the reason I put the slide back up with all of those themes back on, was originally these are the themes that we found were to do with distress. We also found that if supporting the conversations around these areas could generate curiosity in other people's perspectives, a more global understanding, they could start to celebrate success, identify positive things about personal and professional challenges. On a daily basis, I would suggest every medical professional grows. They learn something new every day. And to talk more about that and identify, yes, there are challenges, but look at what we've achieved. And each of these areas, whilst when we first brought them up, you know, it was a worrying area to talk about. They have the potential to generate growth. Which takes me to this slide here. Promoting post-traumatic growth, an area that we've again been doing an awful lot of research in. I think too often, especially within the military and the medical professions as much, but I would say very much in the military, all of these stressors can only lead to bad things. You know, war is a horrible thing, but there's no good. That's quite an odd thing to talk about, but there can be personal growth. People achieve some absolutely phenomenal things. And we've started to do a lot of research and identifying that with support, occupational, organizational support, terrible situations, we can pull through them as we want to do. These are areas that we've started to notice: greater appreciation for life, reevaluating sense of purpose. It's not that we have a measure. It's not a measure that has a cut-off that says yes, you achieved growth, and no, you didn't. It's not kind of simple. I think we're trying to show that all is not dark. You know, even in the trickiest of situations, pull together, work together, come through it. We could take some positives from it. And to summarise then, really, thank you for your time, but to summarise, R3P is a leadership model, and the aim is to support the psychological well-being of an organisation. Like I say, it's the first conversation in a non-medical environment that promotes meaning-focused coping. We do have a lot of strategies in the armed forces and our professions, which are, we give our service personnel lots of emotion-focused coping strategies, and they're wonderful, but not on their own. We need a little bit more. The positive culture of support, we can't stop trying to improve this, to get our people to talk. You know, there's still an awful lot of stigma. There are an awful lot of the people that I see for therapy who have for years been afraid to step forward for many reasons, all of them absolutely valid for them. But it's also a model that identifies that signposting is imperative. Most people will be absolutely fine, but many, a significant number, will require signposting for the further support. So thank you very much for your time. I will sign off. The email there, of course, you're very welcome to send to any questions. But we'll stay safe and take good care of yourself. Bye-bye.
So I'd like to express my thanks to Amos for sending me that presentation of his by email. Apologies though for the sound quality. Hopefully when you or if you decide to review all of the lectures and the recordings of them, that will have far better sound quality than what you just got. So we're now going to take a delayed lunch break, and we will restart with Charlie's session in the next 15 minutes or so with Dr. Marano. So I'm just going to log off and put the screensaver up. Thank you all.